Okay, we're going to start. We're running a little late as it is. Bismillahirrahmanirrahim. Assalamu alaikum and a very good morning to all of you. I am Dr. Saima Salman, and on behalf of the emergency department at the Indus hospital, I would like to welcome all of you to the 4th Biennial conference session on redefining emergency care. We are fortunate that we have local as well as international sector experts to enhance our vision about emergency care in Pakistan as well as global and international care that is being provided to people across the world. Our session was to be chaired by Dr. Abdul Salam from Shifa International, but unfortunately due to his ill health he could not be here. But we are lucky to have Dr. Seemi Jamali chairing the session. She needs no introduction. She is the Executive Director at JPMC and has been the face of Jinnah Postgraduate Medical Center's emergency for as long as I can remember. So glad to have you on board, Dr. Seemi. We will start our proceedings from the recitation of a few verses of the Holy Quran.
Bismillahirrahmanirrahim. In the name of Allah, the entirely merciful, the especially merciful.
إذا جاء نصر الله والفتح.
When the victory of Allah has come and the conquest.
ورأيت الناس يدخلون في دين الله أفواجا.
And you see the people entering into the religion of Allah in multitudes.
فسبح بحمد ربك واستغفر إنه كان توابا.
Then exalt him with praise of your Lord and ask forgiveness of him. Indeed, he is ever accepting of repentance.
One does not ask of one who is suffering, what is your country, what is your religion? One simply says, you are suffering, you belong to me, and I shall help you. This is true for healthcare providers across the world, but it is seen to its maximum in people who are working in emergency departments. It takes a particular set of skills and mindset to become an emergency physician, and I'm sorry, I'm not talking about emergency physicians being thrill seekers or bungee jumpers, but let's be honest, the thrill and the rush that courses through your body when you're running a highly charged course, and at the end of that, the waves of endorphin, when the course is successful, is unsurpassable. We meet people on what is perhaps one of the worst days of their lives, and we try to improve their predicament, and in doing so we leave a part of ourselves in their minds forever. But how do we incorporate a mindful practice into what is a chaotic, complex and ever busy emergency department? What is the way forward for people who are already in the field and who want to take it up as a vocation? What is the future of emergency medicine in Pakistan? Keeping these questions in mind, I would like to call upon my co-facilitator, Dr. Saba, to take the proceedings forward. Dr. Saba.
Thank you, Dr. Saima, and Assalamu alaikum to all. I am Dr. Saba Laila, working as consultant pediatrician at Indus hospital. We would like to begin our session with a talk on integrated role of emergency medicine in a tertiary setting by Dr. Zayed Yasin. Dr. Zayed is the Assistant Director of the Division of International Collaborations in the Department Medicine at the Brigham and Women's Hospital, with focus on intersection between population health and acute care systems. Dr. Zayed Yasin, ladies and gentlemen, please welcome him.
Good morning. Bismillahirrahmanirrahim. So I'd like to speak a little bit this morning
about a question that I think we are all asked in the field of emergency medicine is really why is this a specialty? Why does the world, does Pakistan, does America, the UK, Europe, why is there a need for the specialty of emergency medicine as distinct from cardiology and general surgery and internal medicine? And what is special about emergency medicine, and what is the value that it brings to patients, to the healthcare systems, to hospitals, and to other physicians and the rest of the community? And I think that it starts with the challenges that patients face when they have an acute illness or injury, when they are hit by a truck, when they fall down a flight of stairs, when they come down with pneumonia or tuberculosis, and that very often the care that they need, if it's more than a trivial illness, is complex. And they have to navigate a complex system in order to get the care that they need, usually at a time when their ability, their resources, their mindfulness to be able to manage that is at an extremely low level. And I think the emergency medicine physician is really the person who guides a patient through those most difficult hours. And I think that what will be helpful is to talk about the evolutionary process that emergency medicine happened in the United States. Because right at this point in time, emergency medicine and having an emergency medicine specialist is an assumption. If you go to any major emergency department in the U.S., but that's a relatively new phenomenon. The process and the story starts probably about 50 years ago when an emergency department in an American hospital was really just an emergency room. It was a casualty receiving ward with no physician staffed there, maybe an old leftover bed that was broken and the ward didn't want, so they left it down by where the cars or the horses and buggy could drop it off, and hopefully a nurse there who would be available to call whatever doctor he or she thought would be the appropriate person to take care of that patient. And as you would expect, the care wasn't very good. You were dependent on there being a doctor available in the hospital. You were dependent on it being the correct doctor, and then when you had chest pain, that the nurse thought it was probably a cardiac issue, so they called the cardiologist or the medical doctor, and that it wasn't a pneumothorax and an aortic dissection when you really needed a surgeon. And by the time that was figured out, it was probably too late for you anyway. In order to be able to meet the need of patients there, the hospital started hiring doctors, so you'd at least have somebody available and not just dependent on who the nurse could potentially find somewhere upstairs in the hospital. But that initial generation of doctors who were doing this, there was not a lot of prestige, there was not a lot of compensation, and so you had people who either were trying to make extra money on the side from what their main job was, or people who didn't have a great deal of options. And so that is what I think led to the desire for people to have a real specialty of emergency medicine, because as the technology advanced and we were able to actually do something about acute coronary syndromes, aortic dissection, severe polytrauma, the desire, you needed someone who would actually be able to manage all of that care. And so we moved, and so the specialty was started to be created really in the 1970s, oftentimes by physicians who had returned from the Vietnam War and were used to providing very high acuity, very fast casualty care in a military trauma environment, and then coming back and finding that people who were ill or injured in the U.S. were not able to get the same level of care in the environments within the United States. So now we've managed over the course of the past probably 20, 30 years ago of being a specialty to a point where instead of being an empty room with a broken stretcher and a really tired nurse, it's really the place, the emergency department is designed to be the main portal of entry into the hospital. We have a scope of practice that's defined by the American Committee for Graduate Medical Education to very explicitly state what a qualified emergency physician should be able to provide for their patients, both diagnostically and therapeutically, and with a specialty residency training with subspecialty fellowships. This is something that, for a variety of kind of like social and cultural reasons, the U.S. was one of the earlier countries to be doing this. I think the UK actually even preceded us by a number of years. but within the past 2 decades, it's become the global standard. And really, since about 1990, it's taken off, wherein I think, and this is only update up to 2010, I think that now there are over 70 countries where emergency medicine is recognized as an independent specialty along with equal standing to internal medicine, cardiology, and surgery. And I think it's because the emergency department has really taken on a role that in these societies has been seen as valuable. Valuable because it functions as the interface between 2 different environments, between people in the community, whether they are traditional healers and hakims, hospital outpatient departments and filter clinics, or community-based general practitioners. When the level of care that they're able to provide is not adequate, they do not have the resources. They know they need something for their patients. What's in the hospital? The emergency department is how they get there. And the emergency department is where you can send your patient to wind up being stabilized and then sorted to be sent to the operating theater or the cath lab, if that's what they need, to the intensive care unit, or to the medical surgical wards. But without a well-functioning emergency department, you really have no way of connecting the patient's needs with the hospital resources in a coordinated, rapid, and intelligent manner. By definition, the emergency department has to work at the interface of all the other parts of the hospital. It requires the inputs of the blood bank, of the laboratory, of radiology, and then wind up sending patients to and using the resources of the operating theater, the medical wards, the outpatient clinic. So we've seen in the U.S., emergency medicine physicians are starting to take more and more leadership roles within the hospitals because as chief operating officers, chief executive officers, chief medical officers, and technology officers, because just from doing their general clinical job, they have to know everyone. You can't be a good emergency physician if you don't have a good relationship with your surgeons, your cardiologists, your intensivists, your IT department. And that value that exists within the emergency department has been seen as adding value to the hospital. I wanted to walk through, I think, a little bit of a case example that gives the reason why, from a patient point of view, you would want to have good emergency care and why emergency care really matters. So I want you to picture a busy emergency department at Indus Hospital or JPMC or AKUH. A 33-year-old woman comes in with a severe headache. She's writhing in pain, but as far as we know, otherwise healthy, a little bit overweight. She's placed into bed. It's a relatively light day, so she only waits a little bit more than an hour to see a junior physician who sees that this woman is uncomfortable. He wants to make her feel better. Give her some Panadol, some diclofenac. I hope she feels better. Maybe this is a migraine. I'll come back and see her. 45 minutes later, a patient attendant runs out of the room, runs past the curtain, and grabs a nurse, saying the patient is having a seizure. And soon after, she's not breathing. This trainee doctor, who was a medical student 6 months ago, attempts to manage the airway. There's no one more senior around. They're unable to. It's a failed airway. Initially a gastric intubation. The belly is insufflated. She vomits and fouls her airway. The very thoughtful nurse sees that things aren't going well, calls up to anesthesia, has an overhead page with the on-call anesthetist, and is doing another case. So it's almost half an hour before they're able to be down there and to be able to intubate the patient. And the patient comes into the ICU, having been hypoxic for an extended point of time, having bordered on an asystolic arrest with a hypoxic brain injury. And I want you to think of that same model where a system is organized around having the best possible emergency care. Still seen by a trainee, still is not extraordinarily concerned because, again, this person was also a medical student just 6 or 7 months ago, wants to make them feel better, but the physician has said, you know, this could be a lot of things. I need to understand what's going on in this young woman, and any 33-year-old woman is pregnant until proven otherwise. So about a year in HCG. It's positive. The woman is hypertensive. Could this be preeclampsia? He calls his emergency medicine consultant. They say this could be preeclampsia. Orders IV magnesium and labetalol. Well, the nurse is getting it because, like any emergency department, it's busy. And nurse is trying to manage a dozen patients and their orders and their needs. They call the patient also at 9 o'clock, starts to seize and stops breathing. We get the magnesium and midazolam to the bed. The seizure is aborted, and because you have someone who is qualified to manage an airway, intubated on the first try by a trainee, but with a specialist behind them, and then sent to the operating theater for a stat C-section to treat eclampsia in this previously undiagnosed pregnancy. And I think this is the care that we want to be able to have available to our patients, but it requires the right kind of physicians in the right place to be able to care for the patients. An enormous part of emergency care is recognizing that the general working hours are 40 hours in a week. There are 168 hours in a week. And patients really deserve to have a system that's oriented to deliver the best possible care in that other 75%. It shouldn't matter if you show up at 8 a.m., 8 p.m., or 2 a.m. You should be able to expect the best possible care and have a system that's designed to give you that best possible care. And so, as I wrap up this conversation, I want to talk about the value proposition to really everyone that's involved and why, for hospitals, patients, and other specialties, that emergency medicine as a field is worth investing in. Because there are really 3 essential components to an emergency department visit that I think is a specialized set of knowledge that crosses boundaries between all other fields. There's evaluation and diagnosis, making sure that you have that first, as far as possible, you've ruled out life-threatening diagnoses. Once you know that what this patient has isn't going to kill them, you figure out, can you help them get to a diagnosis subacutely? Stabilization, making sure if they do have a life-threatening diagnosis or a limb-threatening diagnosis or a sight-threatening diagnosis, that you're able to treat it acutely, as well as treating the symptoms and relieving pain. And then disposition, figuring out the next set of care, and as I alluded to earlier, really serving as the patient advocate and navigator, whether that patient needs a stress test in 48 hours, a cardiac cath in 5 minutes, a trip to the operating theater, or just to be established with a primary care physician who can wind up managing their high blood pressure and high cholesterol and anxiety and depression so they don't come in with a STEMI a month from now. The first component of this that I think necessitates emergency medicine as its own specialty is, as I mentioned, the timely aspect to life-threatening procedures. These are all things that someone could wind up needing to save their life within 5 minutes of arrival to the emergency department. And there is no medical specialist other than an emergency physician who is qualified and trained to do all of these things. And you cannot keep, unless you are, even the richest countries in the world, even the Scandinavian countries, cannot afford to keep an anesthetist, a neurologist, a cardiothoracic surgeon on call and available in the emergency department to be able to manage this care acutely. So you need an emergency physician available to your patients. Similarly, for diagnosis, someone who comes in with chest pain, there's a lot in the anatomy of the chest. And the diseases that happen in that area cross the boundaries of any traditional specialist. Aortic dissection, pneumothorax, pulmonary embolism, it's a diagnostic challenge that a pulmonologist or a cardiologist or a chest surgeon can think very thoughtfully about any one of them, but their training and their orientation is not to think about all of them the way that an emergency physician's is. And then the management of the acute pain and symptoms. Managing orthopedic care, conscious sedation, nerve blocks. Again, these are things that these specialties and this knowledge exists elsewhere within the medical system, but not in a way that's accessible to a patient 24 hours a day in any reasonable manner. That's from the point of view of the patient. From the point of view of the hospital, and this is something that visiting the Indus emergency department yesterday I saw very acutely, in that the needs for emergency care, or the potential need for emergency care, can never be met by the supply of the hospitals that exist now, will exist in 5 years, 10 years, probably in 20 years. There's a fundamental mismatch between the burden of disease and the resources of the hospital. So it requires very careful, thoughtful thinking about how are you going to triage those resources? How are you going to make sure that the hospital beds are really used for the patients who could best be used for them? And that is the role of the emergency department. And that is where a thoughtful emergency department can really help a society and a hospital understand, well, how can I best use the limited resources I have available for my patients? And I think that there's a value proposition even personally for other specialties. And I think this is one of the things that has really, in practical terms, driven emergency medicine to evolve as a specialty in the US, because it makes the life better for everyone else. It makes the specialists only have to come into the hospital, only have to come down to the emergency department to interrupt their operative lists, to interrupt their time actually being able to sleep so they can wake up at 5 in the morning to start their list, because they're only called in when they're needed. They, in terms of their managing their patients afterwards, for someone who has a post-operative complication, a wound issue, without an emergency physician, when that patient comes in saying that my wound doesn't look good, my belly still hurts, and I had an XLAP or an appendectomy 3 days ago, do you want an unsupervised junior trainee being the only one evaluating your post-operative patient? Or do you want a consultant who has seen hundreds of these and can recognize sepsis versus just a normal post-operative pain to be managing that patient? And it has value for your trainees. Almost all specialties will need to send their physicians down to the emergency department, either as consultants or as rotators, to manage acute cases. And the emergency department should be a good training environment for them. It should not be a place where a junior neurology or surgical trainee is really running the show, but a place where they can receive quality education from a consultant level physician. So getting to emergency medicine as a specialty is a long journey. In the U.S., it's taken us in the vicinity of in the U.S., it's taken us in the vicinity of 50 years, driven by a lot of both social and financial pressures to wind up being to the place where we are. And there are still a lot of challenges that we're facing. And I think that the challenge in that getting to a system where you wind up having 24-hour qualified consulting coverage to give patients the best care, established training programs, and all the resources that are needed to make good quality care available to the patients is going to take time. But I think that it's a journey that's well worth embarking on. Thank you.
Thank you, Dr. Zayed. We would be having question and answer session at the end during the panel discussion, so kindly hold on to your questions. Our next speaker is Dr. Khwaja Junaid Mustafa, who will be talking about emergency medicine service and training in Pakistan, the Shifa International Perspective. Dr. Junaid did his emergency medicine training in the UK, after which he joined the emergency department at Shifa International in 2010. With a special interest in resuscitation, rapid treatment and disaster management, he is instrumental in teaching and improving the caliber of emergency physicians in the peripheral areas of Pakistan. I will request him to kindly come and deliver his talk. Dr. Junaid.
Thank you very much, and thanks for Indus Healthcare for inviting me, and I feel proud of being the part of this conference. My voice is a bit odd actually, since I left Islamabad, but just bear with me. First of all, just to say a very thank you to Dr. Yasin. Your surname is Yasin, isn't it? Sorry. So I think the next time this presentation is very important. That was a very important presentation. Being the emergency physician family, I think most of us are sold with this concept of emergency medicine. I must say for all the organizers that this presentation should be a part of the preliminary session somewhere at the higher level actually. because we need to convince those people who are actually not sold yet for the emergency medicine. But anyhow, it was very nice to have this all the ideas about the emergency medicine. So where's my? So before going to this my presentation today, I will just talk about the general about the emergency medicine in Pakistan and a little bit about Shifa and the future challenges of the emergency medicine. I still call the emergency medicine as a game changer in the health sector of the Pakistan, especially where we are traveling towards the emergency medicine. We are very much in the initial stages at the moment. There will be a huge talks in the last couple of days, especially on the opening session day before yesterday, the evening, when I had a new information from Secretary of Health and Minister of Health, Provincial Minister and Federal Secretary, and it was quite surprising to know about the health budget, which was almost less than 1%, and knowing with this public sector how they are struggling with the health care, I think I would say that the healthcare sector is in turmoil actually in Pakistan. So we collectively have to do something, and I think in this regard the Indus is playing a very good role. And I think what I'm seeing in future is that public-private partnership will work at least for next couple of decades. The public sector will not itself will, even if you throw like more than, he was planning to have at least 7% budget in next few years for the total budget actually. But I think even then the expertise, the skills and the public-private partnership will work actually. If you see the spectrum of the whole health care in Pakistan, I think there's a big gap actually, a big missing of that jigsaw puzzle, which is the emergency medicine or emergency departments of all public and including private sectors. If you see that right from the basic health unit to district hospital and then the secondary and tertiary care health care, in all that areas, we are almost less than 2% or 5% at the moment, all like trained or qualified people. The public sector people do a lot of give a lot of comments, negative comments against them, but I think the way they are struggling at the moment is it's not the problem of incompetency, it's the problem of skills actually and having a trained people. So we'll go quickly. This is just a quick slide that we are not only the physician as Dr. Yasin said, we are dealing with a lot of things like clinical, non-clinical and academic things as well. So history in Pakistan, just forgive me if there's a numbers are different because I tried my best to collect all the data from different hospitals. So the first training program was started in 2000 in AKUH University Hospital. That was, I think, 4 years training program. The first recognized master training program was started in PIMS in 2009. PIMS is one of the tertiary care hospitals in Islamabad. That was a master program, and they've got like 5 to 6 masters candidates who came out about 2 years back actually. Then AKUH University Hospital again started the first fellowship training program in 2012, and the first 2 fellows are out in 2017. So this was the big achievement. Actually, we have just completed 1 cycle of 5 years training program. Shifa International Hospital in Islamabad, from where I came, we started in January 2013. So our about 3 trainees have finished their training this January. So they will be coming for the exam in next couple of months. Zayed Medical University in Karachi. Just I've been told that about 5 years back they have started their master program, and their first master graduate is out actually. POF, which is a semi-government hospital. It's like a public-private dual type of thing. They have started their first trainee in 2016. They are in the 2nd year at the moment. JPMC was actually the first very public hospital recognized in 2017 last year, and inshallah by this month they are going to start their training program. The supervisors were in the phase of having all the workshops, so hopefully we will be starting the training in this hospital as well. Khyber Teaching Hospital also recognized a couple of months after JPMC. It was actually in November, December, and they are struggling to get through and have some trainees this January, actually in the next couple of weeks. So here we've got Indus as well. So again recognized about a couple of months back, and Dr. Ghazampar, who is actually host today, is hosting us. He's one of the supervisor, and they are inshallah going to start this month, hopefully, isn't it? Inshallah. Okay, so upcoming departments, we have also being the faculty member and being the society person, and in the north we have been working a bit more because of the logistic issues. At times it's difficult to come down to Karachi, but Lahore is one of the upcoming department, is Mayo Hospital, which is King Edward Medical University. They've actually came up with a huge number of posts, although they've got no trained or qualified person, but they are looking for lateral entries, people like having a train in medicine, surgery and peds and orthopedics, and they are actually running the department at the moment. But they are in the process of hiring some trained person from abroad. National University of Medical Sciences is actually in the army. They are also working on that. They have almost developed some internal structure, but still they are looking for a trained person to join them. RMI Peshawar, they've almost completed everything, but it's one of the private hospitals in Peshawar. The visit was actually unsuccessful from the CPSP. KTH Peshawar is actually in the previous list, so we'll take it from there. Fatima Jinnah Medical University Lahore is also planning to start emergency medicine by July 18. So current status regarding the manpower, I'll just go very quickly through this. We've got about 5 departments recognized at the moment: Shifa, AKUH, JPMC, Indus, KTH and WAH. It's about +1. I've just written down that it's in the process. We've got about 10 supervisors, and one KTH one is actually not on the list at the moment, but he should be on the list in a few weeks' time. We've got about 62 trainees, mostly in AKUH and Shifa. There are about 9 trainees in POF. Otherwise, soon the numbers will come from JPMC and Indus Hospital, and KTH will add on that. 7 trainees are in Ireland and UK. It's mostly from the Shifa Hospital. We've got a 5 years training program. They are actually spending 2 years after doing their intermediate module, which is on 2nd year. So they are spending their 3rd and 4th year in Ireland and UK. So we have got few list of fellows and members. We've got first of all, two FCPS in emergency medicine who are in AKUH University Hospital at the moment. We've got about 24 people who have passed IMM, which are mostly in the AKUH and Shifa International Hospital. So they are in the 3rd or 4th year of their training at the moment. We've got a fellow of Royal College of Emergency Medicine. 2 of them, one is in Lady Reading Hospital Peshawar, who has just joined, and one is with us in Shifa. And we have got about 15 people in all 3 or 4 departments who have done their primary of FR camp. We have got few members of Royal College of Emergency Medicine as well. There are 2 in Lady Reading Hospital at the moment, 2 in Shifa International Hospital, and 3 in AKUH University Hospital. Are there 3, isn't it? Yeah. Okay. So just going through quickly from our department, we've got about 47 bedded department. We've got a triage rapid assessment treatment area of 3 beds, see and treat room, which is a filter clinic, 1 room, and resuscitation base 3. We've got 1 procedure room on the front door as well. We've got IE and ENT room with a slit lamp and everything. We've got 4 critical beds, This was just made few months back, because all the intubated patients, I think it's the same in Aga Khan as well, most of the intubated patients, they actually, when they've got no beds in the critical area, they can't go out of the Shifa because of the beds issue in the public hospital. So we keep them, the policy is we can retain them up to 7 days. So we can, we actually ask for the critical care to come down and give us a consult, and our trainees are doing a babysitting for them. We've got a major unit which has got 12 beds. It's like a priority or category 4 patients. We've got a minors, which is category 4-5 patients, 12 beds as well. And we've got 2 negative pressure isolation room, and we've got 8 beds in the peds. So altogether there are 47 beds. We are running at the moment CPSP curriculum, weekly 4 hours protected teaching time, monthly audit and mortality meeting, biannually assessments we do after every 6 months, MCQs, SAQs, and talks as well, which is the OSCE and clinical assessments. We do annual meetings on renewal of their contracts, so we do one-to-one sitting on that as well. And we are, although still struggling, but the rotation with learning objectives. So this is one of the difficult part, and I would say a sore part of emergency physician at the moment, because of the non-compliance of the specialties. We started in 2013 January, and at the moment we have got 2 supervisors and 3 are in the process. We have got about 27 FCPS trainees at the moment in the department, and our 7 trainees are 6 are in Ireland and 1 is in UK. They are in the 4th or 5th year of training. Where we are planning to go for a fellowship in peds, because out of our 6 consultants, 2 of us are pediatric, not emergency medicine, but one of them is FCPS in Pakistan and one is the American board for pediatric peds, and both are actually working in emergency medicine for about 4 years now. We are also thinking on the master program. So this is also one of my topic in the next slide, so we'll go for that as well. So what are the challenges in emergency medicine in Pakistan? Now, seeing globally, we have got a lot of issues at the moment. Maybe different people have got different things in their mind, but I'll go one by one on them. First of all, specialty awareness. That's why I was requesting his talk in future to be on the main talk, so that most of the lateral specialties people should listen this thing, that what the world is going to do at the moment and what's happening at the moment. So in the specialty awareness, there is no political awareness of our specialty at the moment. When you talk about these emergency medicine, they are thinking about the same structure that one of the CMO, SMO is running the department, although at times they wish that there should be someone who should see patients straight away, and there's something in the magic type of thing that 24 hours cover should be there, but again the budget, the resources and the load of work, this all is not matching actually. We have been involved in Kashmir actually. The Minister of Health is a doctor actually, and he spoke to us, and we also only tell them that we can help you in one intervention only, which is the must-need thing in all the emergency departments. There were about 11 district hospitals with 12 hospitals altogether. The capital one was having 2 district hospitals, and it took us about 6 months to train them the priority leveling or triaging system only. So we followed the ESI, the Emergency Severity Index one, and we trained them in 6 months in slowly fashion, and at the end there was a huge positive response from politically and patient wise as well, because there was no cry about category 1 or category 2 patients. So while training this emergency severity index, we only asked them to have some security guard post separately. So they put some security guard people out of the department just to control the crowd, and diverting them like a P1, P2 straight away in the department, and 3, 4, 5 is sit outside and then run biofilter clinics. So that was a huge. So that's the reason of telling this thing is the political awareness, and the guy who understood us, and he was confident to go for this intervention. So that actually created a real impact. Even in organization, at times we are unable to convince them that emergency medicine is so important for you. Your hospital load will come down. Your people will be having a right treatment in the golden hour when they are coming into the department, and everything will come up with the positive things. But again, at times we feel difficulty, and the people like Dr. Seemi, Jamali, and few people in Punjab as well now. I mean, they are our advocate right from like 10 years back, and still it's very hard to give a proper impact on the organizations. Supervisors. This is also our big topic. Very few trained qualified people in Pakistan. We are struggling with the college. I think in last 6-7 months, the faculty and the society and our group has decided to tilt our side towards the universities as well now, because we can't have the real impact in next 20 years, I would say, if we will be sitting just and waiting for the supervisors from CPSP only. And I think the universities are coming up with a master program. Though there's a lot of big debates that the quality of master programs are very poor in most of the areas. So, but I think if we work together, we can improve this quality. So, lateral entry is one of the hot topic in CPSP at the moment, and we are trying to convince the higher authorities to allow the lateral entry people to come and having the grandfather clause to get the supervisorship, because this happened in the whole world, like in America, in UK and Australia. This specialty was developed by the other people actually. So, but anyhow, this is we are working on that. There's a working challenge as well, that how you work in the department, within the department. I mean, when I came to Shifa, the consultant of any specialty was coming down, even their trainees were coming down and saying, do this thing and I'll get back to you. So, and after about a couple of months time, when we had a proper team, we just closed the door and said, when we will call you, just come down at that time. So we are doing everything on our own. So, but you have to have competencies and team before making a proper working pattern in the department. If most of my colleagues are, when they are coming from UK or USA, they are saying this should be like this and this should be like this, footprint process of the patient. So, and I used to tell them that when I came back from UK, I was thinking I'm the most smart and intelligent doctor now. So, but I realized that there were a lot of different things locally on grounds, especially when the trauma came on the resuscitation bay. There were about 5 attendants who were lying down on the patient with saying, Amma, Abba. So I was saying that, I was thinking that there's ATLS, there's nothing written, what to do with these people. So, but anyhow, I just use my other skills to deal with the crowd. So, department working in department within the department is a big science, and it's the local people who can plan well actually as compared to any other person. You can have the ideas, but then the footprint process is very important. Rotation wise, we are still struggling with the emergency medicine rotation across the hospital, though in Shifa and AKUH, most of the consultant and the internal specialties, they are also from somewhere in UK or USA, but soon they are back in Pakistan. They don't realize that it's an emergency physician training. So he is not the year 1 or month 1 trainee of the anesthesia who are just doing a bagging only or basic airway. So, but we just trying to request them that if we are sending you our trainee for 3 months to 6 months, so please just try to take him through everything a bit quick fashion. Although don't say that he is eligible to do the RSI or independent intubations, but at least when the scenario like Dr. Yasin mentioned, that at least he can do something to save the life. So we are struggling with the rotations as well. Training programs. So again, this was the topic, master training program and fellowship training program. Because being a part of faculty and now the dean of faculty, I always come to any department, either it's a public or private, and we as a team also try to help each and everyone to just come up and apply for training department actually. But again, organization willingness, and the other thing is the political willingness. These two things are very important. Otherwise, you can't have the only ED person. If he is interested to develop his department, then it's not possible actually. Master programs, there are 94 post-emergency training posts recognized, and recognized means approved for budget in Mayo Hospital a couple of months back. And they are going to recruit 94 master program trainees in that. So who will look after them? So there's a big issue actually. So but anyhow, we have offered them for any help. Even they can. We have got a list of good trained people now, right from top till Karachi, and we ask them to take all of us in their adjunct faculty, and maybe once in a month we can all participate for a 1 day or 2 day to come up and teach those people on floor and on the classroom as well. So solutions, we have got a little bit of like lateral entry in emergency medicine. We should actually made some rules. I think again the college and university and politically because we have to allow the lateral entry, like if someone is FCPS and PEDS medicine surgery, he should be allowed to come actually as a senior person in emergency medicine while working in emergency medicine. Job structure, I've already talked about the organization and political awareness. Sports and partnership, this is very important that every emergency, like Indus is coming up now as a recognized department. So I think it's Indus' responsibility now is more to help the people around, especially both JPMC and Indus Hospital, if they are now starting their new training program. So AKUH is the best source to have all the input. And it's just a couple of hours talk actually. Once a month you can sit together and see how things are going. So, and the last one is the national leadership and society. I think still we are lacking of having a coordination among us actually, because the reason was that it was only 2 departments for last good 3-4 years, although AKUH was the most senior department, but now we've got a few more, so it's better to have some group and society as well to be active. So we need a team, a shared vision and a plan. So otherwise I think we will be talking the same thing after 5-10 years time. So it can be possible. So this is my message. So we are all tigers here actually, but outside we need to pass this message. So this is my final thoughts. Action without vision is only passing time actually, and vision without action is merely a daydreaming. So we have to have both things together to change the world. Thank you very much.
Thank you, Dr. Junaid. Our third speaker for the day is Dr. Nadeemullah, who will be sharing his views on emergency service and training, the Aga Khan University Hospital Perspective. Dr. Nadeemullah is a diplomat, American Board of Internal Medicine, and has done his postdoctoral training in toxicology from Johns Hopkins Bloomberg School of Public Health. He has been associated with the Aga Khan University Hospital since 2005 and is currently Associate Professor and Chair of the Emergency Department at Aga Khan. Dr. Nadeemullah.
I am ex-chair. I was chair in 2011 and faced all the practical challenges as a leader in emergency medicine. So I'm going to share with you most of the challenges that we faced when we established our first emergency medicine program. And these are some of the common challenges that everyone faced when they established this program in any of the country or any of the organization. So my outline of the talk will be why emergency medicine training, and Yasin has covered most of the points. I will quickly go through these points. And then some of the training challenges that we face in developing the curriculum, rotations, and in developing the assessment methodology as well. And then service challenges, high expectation, high stress, and safety and security that is faced by emergency physician every day in and day out. And then the summary of the presentation. So starting with why emergency medicine training is needed. So we teach treat first, that kills first. So prioritization, threat to life, limb and vision is very important, and this is a unique competency that emergency physician has. And for Pakistan, it provides a safety net in healthcare system for unexpected medical and surgical problems. And as Yasin mentioned, a lot of time-sensitive diseases that requires time-sensitive treatment. So it is a golden hour that makes a huge difference in the whole course of patient disease. And then no hospital can afford to have 24/7 specialties available, critical care, anesthesia, plastic surgery, orthopedic surgery, cardiology, available in emergency, that one emergency physician can fill the gap. And then emergency medicine training is also important to expose other medical students and other specialties to take care of to provide first aid care to patients. And even though they are highly specialized specialties, but sometimes the basic care and basic first aid, the specialty physician does not know. And then there are some unique subjects that we provide teaching in emergency medicine, that are triage, disaster medicine. And this is an eye-opening thing that Pakistan is among top 10 countries, disaster-prone countries. Pakistan is listed as top 10 disaster-prone countries. So disaster medicine should be part of the teaching, and this is in the curriculum of emergency medicine. Then toxicology, although poisoning occurs everywhere in the world, in developing country as well as developed country, but most of the deaths occur in developed countries like Pakistan. So that's why this is also a very important area that we cover in emergency medicine. And then other resuscitation, life-saving skills, and managing multiple simultaneous patients. And of course, very important is a pre-hospital care, EMS service. And this is a sub-specialty also in emergency medicine. So now, knowing why this is needed, I'm going to go over some of the history that we had at AKUH. So emergency services established in 1980s. But it was established without emergency physicians, without emergency training. And first emergency training started, as Junaid rightly mentioned, in year 2000. So 2 decades of gap between services and training. And then we have our first graduate in 2004, and university recognized us as a department in 2008. And we also become a WHO collaborating center for emergency and trauma care in 2010. And guess we have been having training since 2000, and then CPSP recognized us in 2011. So there is a gap of 10 years, and during this period we produce a lot of graduates, but then they did not have the national certification, and they were struggling to get the certification from UK and other places. And then in 2015 we had our first FCPS exam. In 2017 we had first 2 CPSP graduate in emergency medicine. And in this 2017 also, we have also started another training, and this is pediatric emergency medicine training. So a sub-specialty training in emergency medicine started this year. Although CPSP will take another 6 years or somewhere to recognize this as specialty. So challenges that we face. So challenges in developing the curriculum, it was a 6 years of effort. We looked into the requirement of Accreditation Council for Graduate Medical Education. So mostly we followed this ACGME. And then we also looked into the requirement of College of Emergency Medicine UK and International Federation of Emergency Medicine, that is in Australia, but it covers international emergency medicine. But even looking after the curriculum of these 3 accreditation international bodies, there are certain areas which are not covered. Enteric fever, malaria, coming every day in emergencies of Pakistan is not covered in the curriculum of these. So we have to develop our own. So we modified the curriculum according to the national need also. And then of course, laying down the topic will not give you the outcome. It should be an outcome or competency based curriculum. So these are some of the competency, and medical expertise is just one of them. So getting a medical expert is one, he has to be a scholar, a researcher, and then he should be a professional and should be able to do practice-based learning and system-based practice. So these are 6 skills that an emergency physician as well as other specialists should have to become a trained physician. These are the academic activities that we routinely do in our department: emergency medicine updates, grand rounds, guest lectures when international speakers come to Pakistan. We also have our curriculum, M&M and case rounds. In addition to build up research and scholarly scholarly skills, we have our monthly journal club and evidence-based medicine topic review and dedicated research training session. And resident has to do one research project as part of the CPSP requirement and as part of our residency requirement also. Then there are some generic curriculum that we also cover during our residency, which is quality assurance, ethics, policy and procedure, and communication skills and professionalism. And other specialties only do one life support course. So pediatric only do PLS, cardiology and medicine only do ACLS, surgeons only do ATLS, our physician do all. So PLS, ACLS, ATLS, NRP, and we also do which is advanced life support obstetrics. So 5 or 6 life support courses, very expensive for Pakistan. ATLS cost roughly 25 to 50,000 rupees at CPSP. So the huge cost if you get an AHA certification for these courses. So expensive specialty. And we are requesting CPSP to provide us some support for our trainees because they have to go through these courses from their own pocket. And this is the resources. We have it available in AKUH. We have more than 20 databases, including PubMed, Science Direct, Up-to-Date, Cochrane Library, and this is accessible through emergency medicine computers. So during service, they can look into patient problems. Over 4,000 online journals and more than 30 emergency medicine journals accessible to our resident. And we also have our first simulation center, Center for Innovation in Medical Education, where we have a high fidelity mannequin to practice life-saving skills, airway skills, ultrasound, other things. And this is not the emergency room, but rather a simulated emergency room which is built into the simulation center. And we have a high fidelity mannequin that sweats, that talks, that you give a medicine and the mannequin will show the response. The mannequin will cynos, the mannequin will have sweating. So all these things are there for a physician to practice. And these are our residents practicing on in this simulation center and developing their emergency medicine skills. We also have our postgraduate medical education conference, which is generally built on educational themes, and national and international experts participate in these. And then since 2011, we are also organizing annual emergency medicine conference. And so far we have covered the themes of disaster, emergency care for children, and we have also invited national and international experts, mostly from US. And then this year, university has recognized as Year of Emergency Medicine 2018 at Khan University. This is the facility requirement, so you cannot have just a room or bed for emergency medicine. They have to have certain physical facility requirement, and these are triage, state lab, state radiology, pharmacy, critical care beds, non-critical care beds, clinical decision unit, and last but not the least, decontamination room. Consider if a toxicological disaster happened in our country, most of the emergency room does not have a decontamination room, and this will be a hazard or a big disaster again, and healthcare professional will also be involved if they does not have a decontamination room, because it spreads to other healthcare provider. So this is very important facility that emergency room, emergency medicine should have. This is our triage counter. This is our resuscitation room. So just some pictures. The challenges that we face with rotation is, although it is recommended, most of the accreditation bodies say that more than 50% of the time should be in the program. But then if you have so many rotation outside, you are paying the resident from your department, but then they are not providing service most of the time in your department. So we are trying to cut it down because it's not very feasible to have too many rotation. So in the beginning, yes, it was needed, but now we have trained emergency physician available, so they can provide these skills. So hopefully in future, rotation should be minimized and keep to minimum as much as possible. These are some of the important rotation: critical care unit, trauma and general surgery, pediatric, orthopedic, anesthesia, medicine and cardiology. So some exposure to these rotation is essential, but I think most of the teaching and education will be provided in the emergency department. This is our structure of a department residency committee who looks after this program. And then another challenge is assessment of the candidates and to provide them with important feedback. This assessment methodology needs standardization as well as it should have validity, otherwise it's not useful for candidate as well as not for the program. And it has to have formative as well as summative components. So these are some of the methods that we use. So end of shift evaluation, rotation evaluation, 360-degree evaluation, MCQ, SCQ test, OSCEs, DOBS, mini CX, core curriculum test and service exam. The resident goes through these assessment methodologies throughout the year. And then how to manage all this? We have a software which is called 145 software, international software. In fact, we got this. It is a very important software to manage, schedule, assess and track your curriculum, and it is available on the mobile also. So the faculty as well as resident can fill up their evaluation through the mobile, and they can have access to the curriculum through this mobile application. Now coming to the second part of the presentation, which is service challenges. It is recognized worldwide. It's a high stress specialty, and some of the stress comes from abuse of the physician. I suppose it's an international problem, but we see it very often also. So verbal abuse, physical abuse, and I'll show you some of the examples also in my subsequent slides, that our physicians have been threatened for life also. Another problem that creates stress in our physician is high expectation. There is high expectation from patients. You are busy, the emergency is crowded, but everyone wants your immediate attention, immediate treatment, no matter it's P4, P5. So high expectation, and they say, what type of emergency is this? Kaisi emergency hai? This is a common sentence that we hear every day. And then there's a high expectation from the administration also. They want to see that physician should see as many patients as less possible time and provide as efficient care, accurate diagnosis without error, and this is a very high expectation. And then clinical services, they expect that you should have knowledge of cardiology as much as they have. You should have knowledge of trauma as much as you have. Although the emergency medicine is known for its width, but not for depth. And we have been seeing on an yearly basis there is an annual increase in the census, although not comparable to JPMC at all, but for us it's a huge rise. And then can you see there are two bars in each month. The higher bar is patients who are triaged, and then lower bar in every month is the one that are actually registered and seen. So we cannot see as many patients as are triaged. They are waiting and then they left emergency room because it's just too much rush and too much crowded. So there are so many patients who are left without being seen by the physician. And this is a typical picture in the evening in emergency medicine, so much rush at the triage area and everyone is expected to be seen. And this is category-wise patient distribution. So red is our critical patient, red color is the critical patient. So this is the total volume. This is critical patient. These are P3 patients. So most of the patients are P3, but then 20-25% of patients are P1 or P2, which are critical patients. So some facts about ED overcrowding. Our emergency department is responsible for 36 to 40% of all hospital admission at AKUH. And ED overcrowding is a hospital-wide problem. Many solutions for emergency care lies outside the ED. Only when all stakeholders agree that the problem is systemic and hospital-wide solution can be implemented, that will protect everyone access to emergency care. I have listed some of the problems that nobody owns because there are so many differential diagnoses of these problems: syncope, patient with shortness of breath, who has COPD as well as simultaneously CHF, polytrauma. So there is always fight going on which service should admit this patient, because there are so many problems. So issue of an ownership, issue of multiple consult. Everyone wants pure cardiology patient, pure orthopedic patient, and pure their specialty patient. Pelvic pain in female is another problem. You have to call urology, you have to call gynecology, you have to call general surgery, and nobody owns because it takes some time to have a diagnosis. So this creates admission block and throughput. Generally speaking, we should have get him in, get him treated, get him out and move on. But if the tub is full and the clog is blocked, then of course there is no output, then there will be overflow. And I'll tell you some of the security and safety problems that we had. This was Eid Day, which is a festival, important festival in Pakistan for Muslims. 2 patients with 2 attendants, all young, energetic. They had minor injury, they had RTA, road traffic accident. They were stable. They already received first aid from another hospital. So this was the second hospital. They come for further care. At that time, ED was busy. It was diversion. There they were explained diversion. So violence resulted. And what happened? We have a security guard, we have a panic alarm. When we press panic alarm, extra security comes to emergency department from the main security office. So security guard and panic alarm did not help. We have to call the Newtown police, which is the closest police station. So police could not help. Triage and registration desk empty for 2 hours. And staff and physician were emotionally traumatized and thinking to switch the job. I'm sure JPMC will have more experience of these things, but these are some of the experiences. Another problem, a man with a woman came to emergency room. So man was having fever and it was P3 patient, not P1, not P2, not priority 1, not priority 2. He was vitally stable. The patient and the attendant were explained about diversion. So patient took out the gun and the woman said, "Sabko bhoon dale." The administrator on call was present and then we were forced to see the patient because he was politically influenced. So conclusion, emergency medicine training is emerging need of the country. Emergency medicine residency training provides standard of care for acute illnesses. Despite current difficulties, the future for emergency medicine in Pakistan appears bright. Thank you.
Thank you, Dr. Nadeem. Our next speakers are Dr. Saima and Dr. Javedia. They are working as assistant professor at Jinnah Postgraduate Medical Center. The topic of talk is emergency medicine and training in Pakistan with focus on the JPMC experience.
Thank you. It is a matter of great pride and joy for me today to be the representative of the biggest institution of Pakistan, that is the Jinnah Postgraduate Medical Center, which is a center of excellence in providing healthcare to the largest strata of the society. This JPMC had been working since a long time in the history, and today I am one of the proud member of this community. Today, both of us will represent the few glimpses that JPMC has imparted to the healthcare services in Pakistan. So JPMC is a leading contributor to emergency and trauma care services in Pakistan. As you people know that emergency medicine has been evolving since the ancient times, and it was also present in the Napoleon's time. So when the patients were usually treated in the battlefields. In Pakistan, the model of emergency medicine is basically the American model. That is, the bringing the patient to the hospital and not the Franco-German model, which is bringing the hospital to the patients. So it started in the ancient times, and Napoleon's chief surgeon, Dominic Jean-Larry, he was considered to be the first surgeon in chief, and he was the innovator of the battlefield surgery. For the first time, he invented the system of ambulances in the battlefields. He started treating the patients while in the battlefields, and he is doing the surgery in the battlefield, and as you can see this in the picture. He was the father of war surgeries, and he for the first time innovated the system, the ambulance system, and impressive was the speed of this French artillery carriage, which was called as ambulance volantes at that time. This was innovated by this French surgeon. So in 1960 and 1973, the emergency medicine is still growing, but at a close pace. So here comes the role of JPMC in providing emergency and trauma care services. We had been working since long to provide emergency services to the society, and Jinnah Postgraduate Medical Center is one of the leading tertiary care hospitals of the country, and the Department of Emergency Medicine is the pioneer for providing services to the large strata of the society. So our journey started from 1930, when the first building of JPMC came into being. This is the old Ward 5 and Ward 7, and it was named at Medical Corps Hospital. It was established in a new building. In 1942, you can see Royal Air Base Hospital was working, and Pakistan Central Hospital at the time of independence, and after independence, the father of nation, Qaeda Muhammad Ali Jinnah, was requested to lend his name to Jinnah Postgraduate Institute, which he graciously accorded, and so it was named as Jinnah Central Hospital. So later on, the Jinnah Central Hospital, along with the BMSI, because of both, they were joined together. It was a joint venture of Government of Pakistan and United States. So Jinnah Postgraduate Medical Center came into being in 1959. Over the years, Jinnah Hospital has been growing. There are construction of the new buildings. The new equipment has been installed. And can you see the face of JPMC is now changed. It is the biggest equipped hospital and one of the modern hospital which can actually provide the standards of care which are required in the 21st century. So this is the main gate of JPMC. Karachi, as you know, is the center of the financial, the trade and the cultural hub, and Jinnah is the center of Karachi. This emergency department was basically renovated and refurbished in 2008, and the space was expanded. The emergency department is headed by Dr. Seemi Jamali, who is the executive director and in charge of accident and emergency department. And she had been working for the last more than 2 decades nurturing that department, and all of the people know her commendable role in the health service delivery across the whole city. So I will show you some of the important historical roles which emergency department played, and there is a long list of incidents that we have managed. The recent incidents is the heat wave in Karachi. When the whole Karachi was scorching with excruciating temperature of around 45 degrees centigrade, it was basically the Jinnah hospital to whom all the public rushed, and the Jinnah hospital, can you see, was crowded of the people who are taking their patients to the emergency department. So with a constant influx of the patient, thousands of the patients have been referred to the 3 hospitals from the suburbs of Sindh as well as Karachi, and all these patients were taken to our hospital, and we tried to give them the best treatment which was possible in those days. Can you see, this is the data of only 15 days, and thousands of the people visited the emergency department, and there was a good number, more than 380 deaths which were reported in only 150 days in JPMC, and the death toll was very high across the whole country, across the whole Sindh. So the second incident which occurred very recently was the train accident at Landhi. One bogie collided with the train which was already present on the platform, and 3 bogies were completely destroyed. So all the patients were shifted to Jinnah Hospital. We gave immediate care, immediate treatment to these patients, and many of the patients were successfully rescued. So there is the third incident, which is a fire incident at Regent Plaza. So a pre-dawn fire basically erupted in this hotel, and many hundreds of the patients were rescued from this hotel, which were immediately shifted to Jinnah Hospital. And no one can forget this important incident which occurred in Karachi in 2010, where the 2 bombs were blasted, one in a religious procession, and the second bomb was blasted in accident and emergency department when the injured patients were being shifted to the department. So as a result of these bomb blasts, the whole of the departments came to a standstill. Can you see the damage after the bomb blast? All the patients were terrified. All the doctors and the paramedic staffs were horrified. But still, we were working under the leadership of Dr. Seemi Jamali, who is the head of accident and emergency department, and her services will never be forgotten in the history. So it's not only the emergency medicine. We are trained like doctors, paramedics and nurses, but in the emergency department it is like working in a war. Now we'll take you on a virtual tour to our emergency department, and this part of the presentation will be done by Dr. Saima.
Assalamualaikum. Dr. Saima is here. Let's have a virtual tour of our busiest and the largest emergency department of Pakistan. Emergency departments are very crucial in any healthcare system, and we are available 24 hours a day, 7 days a week, and 365 days round the year. These are the part and parcel. These are our backbone, without which we cannot manage our emergency department. This is our male ward, as well as we have another female ward, and there is backup area which can be converted immediately and it will be operative. This is our ICU, which is well equipped, and we have a resuscitation area where we manage the patients according to ACLS, ATLS and BLS protocols. ICU has 3 ventilators and 3 bedded facilities. These are our OR, which is ready for 24 hours. Our physicians and surgeons, they are on their toes to help the patients. This is the recovery area, and we are supported 24 hours by the radiological team, which do ultrasound and give X-ray facilities, and as well as we have C-arm facility as well. This picture depicts a treated patient discharged from the hospital, and this graph shows the trends of the patient, which was more than 1,30,000 in 2000 and gradually raised more than 2004. We have managed a disaster plan to combat any disaster, as we are the front fighters. This is our future vision, which is a surgical complex under the leadership skills of Dr. Seemi Jamali. We are expanding our emergency skills under the leadership skills of Dr. Seemi. Thank you.
Dr. Salam.
Assalamu alaikum. I'm Dr. Salam and I'm working with Aman Foundation, and thank you so much everyone for your talks. So everybody's talked about pre-hospital care, and I'm not going to put up a question because I'm already working in that sector, but I thought it's kind of important to just put it out there. Yes, we have several partners when we talk about pre-hospital care, and Aman is one of them. Just to put it out there, everybody has kind of pointed out the role of the government in a public-private partnership. So the good thing is that the government has already put in a hand in this. They're coordinating with Aman, and they've extended. Aman has developed a public-private partnership in terms of developing Karachi itself and extending their ambulance services in Karachi as well as in Sindh, which we're working in two sectors, which is Badin and Sajawat, and we're going to extend further as well. On the other end, we are trying to improve the pre-hospital care system in terms of improving pre-hospital care, their teaching systems, and developing updated systems like telemedicine as well. So these are some of the things that Aman is trying to push on their end. We are also trying to coordinate with EB and Shifa, who are key members in the pre-hospital setting. And we hope that collaboration will we'll be able to kind of get there, sooner than later, because that is the agenda, and that's how we're going to progress. So that's just a short bit on my end on pre-hospital care.
So at the end of the session, what we have learned perhaps is that an integrated approach, instead of working in our own little circles, we need to get together, improve upon our pre-hospital care, our hospital care, and later the definitive care that has to be provided by the people to whom we hand over the patients. So I would like to request Dr. Seemi to kindly conclude the session by a few remarks.
Well, I think this has been one of the best sessions that I could have heard this time. It was brilliant to hear Dr. Adil, Dr. Zayed, Yasin, Dr. Junaid, Dr. Nadeemullah, Dr. Megan, and Sean. And of course, doctors from my hospital, Jumeirah, and Dr. Saima. And I think the best approach would be an integrated approach, and I think that is the best way to go forward. We need to now go forward, and it's high time, we get onto petty issues and, crying and cribbing over small things. We need to move forward, and I think this is the right time and this is the right opportunity actually to move forward. And I think these were wonderful presentations. Every aspect of emergency was covered, and also the trauma, because I want to say one thing, that some time ago we had done a research on the kind of patients that came to the emergency, and we saw that about 65–70% were medical patients with medical emergencies. And right now, if you look at the emergency department of our hospital, it is about 45% of the total number of patients that are coming right now are those of trauma. So it could be a firearm injury, it could be an accident, it could be just a head injury, it could be from anything. So I think that trauma also needs to have a significant role in the Department of Emergency, because if we cut that out, then I don't think we will be able to achieve our target. So thank you very much everybody for making your presentations and being here.
I request Dr. Abdul to please come up on the stage and distribute the sheet to our participants. Dr. Khwaja Junaid Mustafa. And Dr. Nadeemullah.
Okay, sir, look at.
I would now like to request the medical director in this hospital to come up upon the stage, Dr. Ashraf, and distribute the rest of the sheets. Dr. Sean Kivlehan.
Sir, please look here. Wait for video. Thank you.
And Dr. Megan Rybarczyk.
Ma'am, look here, please. Then. Thank you.
Dr. Kivlehan from JPMC.
Okay, look at the camera.
Thank you.
And Dr. Saima, JPMC.
Okay, look at the camera.
Done. Thank you.
So this brings us to the
वेट करेंगे. वेट कीजिएगा. वेट. Thank you.
Thank you both of you. Our next speaker is Dr. Kivlehan. Dr. Sean is the Director of International Emergency Medicine Fellowship at Brigham and Women's Hospital. He has worked in collaboration with WHO and has helped in the development of their emergency care course. His current work involves developing and researching emergency care and global disaster response systems. Dr. Sean will be enlightening us about global trends in emergency medicine training. Dr. Sean.
Everybody, thank you so much for having me here as a guest. It's a true honor to be here in Karachi, and all the people that I've met have been, it's just been really an amazing experience, and how far emergency medicine has developed here already is just incredible to me. Before I go into my remarks and what I was going to say in my presentation, I just have a few thoughts on things that were already said that I wanted to point out. And I think the most important thing is what we think of as the latent need for emergency care. So in one of the slides in the previous presentation, it showed the volume of patients, and I think it was something like 400,000 annually. So it's almost 500,000 patients are coming annually. And what year was that emergency department opened?
This emergency department has been working for a long time, right? But this was the 2017.
So think of before that department existed and before there was emergency care. Where did those 500,000 people go for care? They still needed care. The need was there. There was no service. And the other thing is, every single ER statistic I've seen so far, you can see the graph is rising steep and steady every year. And what that tells me is that there are still so many more people in Karachi and Pakistan that need emergency care that aren't getting it. And as we increase capacity, it just speaks to the need and how important this is and how the difference that it can make. The second thought I had was what was described as challenges in one of the previous talks. And two big challenges of emergency care that we encounter in Boston and everywhere else that really, I think, brings us together as a specialty and creates a family feel, because nothing brings people together like complaining about the same thing. So it's ownership of complicated patients and flow. So I would say ownership is some of the things that were pointed out. Polytrauma patients is a good example. You have a patient with a head injury, with an orthopedic injury, and with an abdominal injury. Who should that patient be admitted to? And there's always debate, and for good reason. They want the best place for the patient. The syncope patient, should they go to the medicine service or the cardiac service? The GI bleed patient, and the list goes on and on. I don't see that so much as a challenge. I see that as the opportunity and part of the reason that the specialty of emergency medicine exists. Because medicine is not black and white. It's not clean. It's gray. Almost all of it is gray. It's very rare that we get the nice, straightforward case where it's obvious, oh, this person's having a clear heart attack, STEMI, they need a stent, that's it. Those aren't the cases that make our job difficult and make us think hard. Those are the easy ones. It's all the complex interactions. And that's why emergency medicine is great, and that's why we need emergency medicine, to fill that gap and to bridge that specialty, because the training is so diverse. And flow is the last thing I want to mention, and it's another challenge. I love the bathtub, and I'm going to steal the bathtub picture because that is a perfect example of the emergency department. You want the tub full, but all the time, but you need it to be, the drain to be unclogged. And it doesn't take much for that drain to get clogged, and when it gets clogged, the bathroom floods very quickly. So, and then we're all underwater, and we've all felt that. So I see it again as a huge opportunity for emergency medicine, because the unique thing about emergency medicine is that we interact with every other specialty in the hospital every single day. Very few, if any, other specialties will speak to a radiologist, to a surgeon, to a cardiologist, to a pediatrician, to a primary care doctor, all in the same day. And as was mentioned, the IT people usually we speak to at least once a day too. So again, instead of a challenge, I think the flow issue is an opportunity, because we understand. We can speak a language. During a shift, I know all of you too, I can call a urologist and speak their language. I know how they want the urine described and the different shades of fruit punch. And then I can talk to a cardiologist, and I know they want to know when was the last echo and what did the cath show, and what are their risk factors. So being able to speak the different languages makes us fluent in all of this. And then we can come up with flow solutions that affect the whole hospital, and that improve not just the ED, but really the whole hospital, because nobody else bridges everything like us. A hospital administrator may try if they have enough clinical experience, but even then, they're either non-clinician or they came up one specialty, so they understand that specialty. So I just think it's really important, and it speaks to why emergency medicine is so important and why it's growing. So with that, I'll go into the trends, and I think that ties into it a lot. So I'm going to give an extremely brief history of emergency medicine in the United States, and just to show that emergency medicine is not old, as has been said before. It does go back to the Napoleonic Wars, and particularly Vietnam is when it really matured in the 60s and 70s. But in the United States, it was only in 1968 that the American College of Emergency Physicians was formed. So not that long ago. And that doesn't mean that emergency medicine was recognized yet. That was just when a bunch of physicians working in other specialties, mainly general medicine and surgery, got together and realized this need, because the need was there and it wasn't being met. The first United States emergency medicine residencies came about in the 1970s. So again, not that long ago. And many of my mentors and people that I worked with when I was a resident, and some people that I still work with now as co-faculty, were part of that initial wave. So some of these people are still practicing, and it's amazing. You can speak to them and just hear about how they brought the specialty and the challenges. The first emergency medicine journal in the United States was in 1972, which was called the Journal of ASAP. Now it's Annals of Emergency Medicine has evolved into. So that came a long way to bring legitimacy to the field, because until you have a research base and an evidence base and people doing proper peer-reviewed work, you're not going to be able to convince other specialties who have been established for 100, 200 years that not only are we needed, but that we're intelligent and that we think about things, and we're not just these weirdos down in the basement of the hospital doing random care, that there's actual evidence. It was 1979 that the American Board of Medical Specialties recognized emergency medicine as a specialty. So it's the newest of the main specialties in the United States still today. And this wasn't accepted on the first application. It was actually, I think, the second or third application had to be revised until the American Board of Specialties agreed that emergency medicine should in fact be a specialty. So it was a battle. It was a battle fought by people that are still out there today, and it's incredible that if you ever have the opportunity to hear them speak, that you should do it. And in 1983 was when the residency programs were formalized and involved in what we call the match in the United States, which many of you are probably familiar with. But it's basically the algorithm of how medical students decide where they're going to do residency. and it's a formal program across all specialties, and emergency medicine wasn't initially included in it because it wasn't seen as a true specialty. So it's only 50 years, and it's incredible to see. This year is the 50th anniversary, and there's a lot of material online and stuff to learn about it. And it's fascinating to me because I wasn't around for all this, and some of us take it for granted. I'm much more on the junior faculty side, and we take it for granted that of course there's emergency medicine, of course there's emergency rooms, and it wasn't always that way, and take advantage of the fact that we can still talk to the people that were there. So in the United States, the emergency medicine residency programs, currently there's 191 programs now, which is incredible. And that's risen even since the time significantly since the time I've entered residency. I'll show you a graph in a moment. There's just over 2,000 positions a year, or this was from 2017 match. 2,000 positions for emergency medicine were offered in the United States, which is a tremendous amount considering that this, again, it speaks to the need that this didn't exist. And 50 years ago it was ASAP, but really 30 years ago it was residencies. And in 2017, those positions were filled 99.7%. So emergency medicine is, and the 2 prior years, it was 100%. So that was only 6 positions out of 2,047 that went unfilled, making emergency medicine one of the most competitive specialties in the United States. It's been top 5 competitive for the past several years now. And because not only is there a need for it, but that there is also a big interest. And this is good for our specialty, but most importantly for our patients, because what this means is that we're attracting the more intelligent medical students. Every year, when we look at the applications for residency and for the medical students applying, and we look and say, oh my God, I never would have gotten in. So these people are so incredible, and every year it gets better, and that's great. That's what we want to see. And this is just a graph to show from, and this is current up to 2017, and you can see the trend of the programs. That first year is 1974, and there was, looks like 11 programs, 12 programs. So in that time frame, you can see how rapidly it's grown, and only over the past few years it's jumped significantly because there's been a push by the U.S. government that has realized that we still have a tremendous shortage of emergency medicine physicians, and there's been a big push to expand residencies. This is just a map of the United States showing where it is, and you can see that we still have regions that are not well covered, and you can see up here, right here, there's no residencies for all of these states. So less populated, but still large part of the country, and so there's still gaps that we're addressing. And Hawaii and Alaska also have no residency programs. So now that's the trends in the United States, and then IFEM was brought up briefly, the International Federation of Emergency Medicine. They're based in Australia, but they what they are is they're an organization of organizations, and so it gets very kind of meta and a little higher level. But it's useful because what they do is they gather the organizations from every country. So in the United States, it's ASAP. And then you have the UK company, the Royal Physician of Emergency Medicine. You have Australian Society. You have various other countries. And I know it was mentioned that in Pakistan there is not yet a society, and that's a big step to getting the brand out there. It's almost like marketing. I think he said that the talk should, or Zayed's talk should have been in the plenary session, because it is. There's a marketing aspect to this, and don't be fooled. We need to let the public know that we're out there, but also our other physicians. So IFEM is a great resource. They have a website. It has extensive resources, not just on curriculum programs, but also how to form your own agency and learn from the other countries that have done this. Similarly, ASEP has a section on emergency medicine internationally, and here there's a program called the Ambassador Program, which gathers programs from every country almost in the United States. This is from the ASEP conference last year. These were the countries represented, and you can see many countries are here. I don't remember the exact number, but not every country. You'll note that Pakistan is absent from this list. So this is something I'd say a low-hanging fruit or an easy target, because to send somebody to this meeting next year, because what is discussed here is the core curriculum for emergency medicine that is developed in conjunction with IFEM. And that curriculum can then be taken and adapted to the local needs. Of course, there are some things that are not well covered, which is mentioned and is absolutely correct, like tropical diseases, malaria, things that are not always seen in higher income countries that have a leading role in this. But that framework can be taken and then adapted secondarily. So getting involved in things like this at IFM and ASAP is very important, and I can talk to you after if you want the information. But this is where the curriculum is developed. This is from IFM. This is some curriculum guidance that they've developed, and this is just 3 examples. This is all freely available online, and you can dive into and look at yourself. But they talk about undergraduate curriculum for emergency medicine, higher level graduate curriculum, and then ultrasound guidance, but it goes on much more. And these are all things you can get involved in on the committees as well. Most of the work is remote, and you can be a part of developing this curriculum. This was mentioned earlier as well in the United States, the ACGME, or the Accreditation Council for Graduate Medical Education. This is really the governing body for all medical education in the United States at the residency level. And the emergency medicine, once it was incorporated, you can go to this website, and they have a curriculum process that is very thoroughly outlined of what are the competencies, what is the definition of an emergency medicine provider, what should you be able to do. And a big discussion for emergency care is always, where does it stop? So it was mentioned before, which is correct, that we're a specialty of breadth, not depth, and which our strength is our breadth, and our challenge is our lack of depth. So you have to decide for each thing, how far do you go? So if you're managing a patient with a heart attack, to use that example again, well, you can give aspirin, you can give heparin, you do EKGs, you do IVs, but we're not going to put the stent in. So at what point do you transition that care? And ICU patients, so that's pretty abrupt and clear. Or a surgical patient, well, we're not going to do the surgery, so they're going to transition to the upper room. But ICU patients, particularly medical ICU patients, the continuum is a lot more gray, because in theory they can be managed indefinitely in ED, which, as we all know, happens, and we enjoy that, but it affects the flow, and that's why we need to work closely with other people. The last curriculum example from the U.S., this is a really useful one that's free online, and this is what the board exam is made of, so this is always the most useful thing to learn the curriculum from, is the people that write the test that you have to take to graduate. So the American Board of Emergency Medicine, they call it the EM model, and this is what the actual core curriculum and requirements for emergency medicine training is built off of, and you can see that link. It was just updated in 2016. And it's free access, and it's a massive document, but it's very useful about what is an emergency physician, and what should we be able to do. Now to transition out of the U.S., and to address the point that was brought up earlier, that a lot of these guidelines and these current curriculum documents for training are based in North American, European, Australian countries that aren't always applicable to settings like Pakistan and a lot of other parts of the world. So several years ago, a group of ER people got together and formed AFEM, which is the African Federation of Emergency Medicine. And it's a consortium of all the African countries that are recognizing emergency medicine, and they've created their own curriculum, which is a curriculum that fills in all those gaps, and is specific to tropical settings, to under-resourced settings, to settings that may not have complete hygiene and sanitation programs that see these diseases. And it gives guidance on that for emergency medicine. So it's useful to look at, and they go through a whole curriculum. This is just a screenshot, but you can go through online for free, and I think it's an incredibly useful resource. They have, as part of their curriculum, they have an accompanying full PowerPoint that was developed that is written in simple English, so it's meant to be translated to multiple other languages easily with photos, so it's all freely available in stock use. The only thing they ask, if you use it, it's just that you say where you're using it, so that then they can further market all these places are using it. And they encourage contribution from everybody. And to use the African example, just because this is where I've done some work on global emergency medicine training, this is the emergency medicine training program in Africa, and you can see there are only 8 countries in Africa that have emergency medicine training programs. So we still have a long way to go, and although it's growing quickly. This is one emergency department in Tanzania where we started an emergency medicine residency program, and this is where AFEM was born out of, here in South Africa. And here I'll give some examples of emergency medicine curricula. So in the United States, emergency medicine curricula for residency, postgraduate training is 3 to 4 years. So it depends. There's an ongoing debate still of whether it should be 3 years or 4 years. And the consensus is really that it should be 3.5 years, but that just doesn't work, so people can't decide. Which I tend to agree with that. I think looking at the components, you could do it in about 3.5 years. So right now in the United States, 25% of the programs are 4-year programs and 75% are 3 years. So the vast majority are 3 years. I'm biased because I attended and now also I attended a 4-year program and now I work at a different 4-year program. But if you just need the core components to just be a standard emergency medicine physician that has no interest in academics or research and you just want to go out there and take care of patients every day, probably 3 years I think is completely adequate and you can get the core knowledge and get into the workforce. And then for people that want to do broader work in specialty or expanding horizons, the 4th year it gives a more spread out schedule that allows you to explore research interests and methodology, so it gives you more time. In Muhimbili here in Dar es Salaam, the program is 3 years, and we started. This was the first emergency medicine program, residency program in Africa that was created. It's now in, I believe, its 7th year now, and has graduated 3 classes, about to graduate the 4th. And it creates a diaspora, which you guys have probably seen, where the physicians that graduate, they are by design, they're not allowed to stay there. Only 1 or 2 do. And they go out to other hospitals and they become the chiefs of these new emergency departments. So they become kind of administrators. But it gets the knowledge and the word and the marketing out there. And then in return, people that attend medical schools see these new emergency physicians as role models and mentors, and then they eventually, years later, they go to medical school and they say, maybe I want to do emergency medicine. And that's how you promote the specialty and grow it. And this is a 3-year program which had all the challenges that are mentioned. You have to work with other departments, and I'll talk about that in a minute, because the way we interact with everybody means we have to work with everybody. This is another program that I work in Haiti, and this is in Mirabelais, Haiti, and this is the emergency department entrance. And this was the first emergency medicine program in Haiti that we created, and it's a 3-year program as well. So you see, I think 3 years can work, especially in the early years when you're trying to ramp up and produce positions to create a need in the country. And here we just graduated our first class just this past September. So, and now we graduated 6 people a year, and of those 6, 2 stayed on as faculty, and the other 4 have gone elsewhere. And each year we've seen the applicants. The first year it was kind of scraping the bottom of the barrel. The applicants didn't really know what emergency medicine was. We didn't have any reputation. People were a little hesitant to say, do I really want to gamble on my career and do this emergency medicine thing? I think I'm just going to go and be a cardiologist. And I don't necessarily blame them for not taking a chance. But now every year we see the applicants get more and more competitive, and we're getting better and better medical students. And that's how it grows, because that translates into better care for our patients. Just some examples of training in other countries. So Australia is about 5 years, and in Canada it's also a 5-year training program. And the UK has varied their systems a little different, and I think it's you do a 2-year internship and then you have to do a specialization. So it's 4 years altogether, or 5 years. So it's longer. So this is an ongoing debate, and I think you can make an argument for 5 years too. There's no clear answer is the short message. But I think what is the clear answer is what the typical curriculum entails and contains. And I know this is going to be talked about in a little more depth in another talk, so I'm just going to briefly go over the components. Obviously, emergency medicine. The majority of your time should be spent in the emergency department learning emergency medicine. But that's not enough. You need ICU time, and not just any ICU. You need medical, surgical, and pediatric ICUs. Sometimes there's other specialized ICUs. Personally, I feel they're less important. You need the core knowledge if you're going to, because this is what you're expected to manage in the ED and to be able to essentially do everything an ICU can do in the first several hours in the ED. There's a good saying by a person in the U.S., Joe Lex, who's a long-term emergency medicine educator, a well-known person there. And he has a quote that he says, emergency medicine is the best 10 minutes of every other specialty. And I agree. I mean, I think most people that went into emergency medicine, they agree with that statement. And that's because I remember being in the ICU and saying, well, this is, when I rotated in the ICU as a resident, and saying, well, this is kind of boring. The ER already did all the fun stuff. And now we're just going to sit here and, you know. So I think I made the right choice. But obviously, there's trade-offs, and there's benefits of all the other specialties as well. Pediatrics is important. It's, I mean, in most standard places, 1/3 of the patients you're going to see is pediatrics. And there's a debate in this, but I'm personally in the camp that the dichotomization, that the dividing between pediatrics and adult patients in emergency medicine is false, and I think that it's not a good idea. I think that an emergency patient is an emergency patient, and emergency providers should be trained to take care of whoever comes in. Because by definition, when an emergency happens, it's not planned, and the person needs care immediately. And that may be a child, it may be an adult, it may be medical, it may be trauma. So that's why it's really important to have pediatrics incorporated in their training. Trauma, of course, and to be able to take care of traumatic injuries. And this is one of the biggest benefits that emergency medicine can bring, I think, because many traumatic patients have medical problems too. Perfect example is the person who has a syncope and then a head injury. So now they're medical and trauma. Well, that's what emergency medicine is all about, being comfortable with both. Orthopedics as well, and many minor orthopedic injuries. This is a good example of how somebody said earlier, I forget who it was, that one of the benefits of emergency medicine, the more practical benefit, I think it was Zayed, is that we make everybody else's life a little easier, hopefully, on a good day. I mean, I think some consultants would argue with that statement and say we make their life more difficult. But I like to think that we make their life easier, because now think of the orthopedists who used to have to come in and splint every bone. Now they don't have to. They can just see them in clinic and follow up, and they don't have to interrupt their day, which is already full. So it provides a great service to the healthcare system. OB-GYN, for obvious examples as well, and although much of this is still diverted to other facilities or other parts of the facility, when people need help, they're going to go to where they need help, and every ER doctor needs to be able to deliver a baby and manage gynecological emergencies. Anesthesia, not just for the intubation, which is always the part that's talked about, but also for the peri-intubation management, which is really the more important part. I always tell our residents, I think anybody could learn how to intubate. The physical task of intubating is just like any other physical task, but it's learning all of the mechanics of the medications that you use before and after, how to manage that. That's the real challenge, and that's what you can learn from anesthesiologists. Ultrasound skills are so important. Point-of-care ultrasound should be available and is the standard. Neurology, as stroke patients come in, and understanding how they think about strokes and how to do a proper neurologic exam. Emergency medical services is something that's so important, because the pre-hospital environment is really part of emergency medicine. You have to understand it, because this is where your patients are coming from, and you need to work with their staff. Then various electives and a list of all the core skills that are needed. So beyond the training, there's fellowships, and it sounds like there's already some fellowship programs being started now. And I'm just going to go through a very brief list of the fellowship opportunities that are available, at least that I've seen in the United States. This first column on the left are things that are ACGME accredited. So these are formally certified by the GME Council. And so EMS fellowships, these are people that want to go on and then lead an EMS system, so they become the EMS medical director. Toxicology services, pediatric emergency medicine that want to subspecialize in pediatrics, sports medicine, hyperbaric chambers, and clinical informatics. So these are all the ones that are formally accredited. But then on the right column, there's many others that are not formally accredited, and this is not even a complete list, because there's even more than this. But critical care, and more we're seeing people that work in ICUs in the United States are actually emergency physicians who do a critical care fellowship, which is relatively new. 10 to 15 years ago, that was essentially unheard of. The paths were medicine into pulmonology, anesthesia, or surgery to critical care. And now emergency medicine, which it makes perfect sense, and we're seeing up to 20 to 25% of newly boarded ICU attendings are emergency medicine trained, and that number has been rising steadily, and I think it will continue to rise. Ultrasound training, people that specialize in ultrasound and work more in the field, closely with the field of radiology. International emergency medicine, which is what I work in and our fellowship, and it's essentially the exportation of our specialty, and to help facilitate the training and growth of emergency care around the world and to provide better care. Health policy, wilderness, so for very austere settings, people that are in the mountains or hiking, things like that, and simulation fellowship. So there's all of these opportunities for extra training, and the list goes on and on. And this is just to show the growth of, this is updated through 2017, of some of the fellowships, the accredited fellowships. You can see the EMS one has skyrocketed over the past several years, and how many of these fellowships exist in the U.S. Lastly, I just want to turn attention to locally here in Pakistan. So in preparing this, I Googled just emergency medicine in Pakistan. I tried to find what's out there on the internet. And I had already heard of, obviously, it's very well known, and I know several people that have interacted with it. And this is their curriculum that I just pulled from the internet, so many of you are probably already familiar with it. But you can see the core components are pretty similar right here, and then you can see the shorter things, the 2 weeks, or these smaller electives like ENT, ophthalmology, which are all these things. Because do you think if a patient has an eye complaint and suddenly loses their vision, they don't say, oh, I need to find this specialist, or they don't want to wait to make an appointment. They're just going to go to the ER. So you have to be able to treat everything. That's the great thing about the ER, but it is, of course, the challenge. That you have to take care of everything that comes through. I'm going to close with this last piece about the World Health Organization and looking at emergency care training as part of the emergency care system and looking at the much bigger picture. And this is the emergency trauma care office. And they've developed this kind of framework infogram, which I think is useful to think of emergency medicine. And as you go forward, thinking if you're already working in the field, how you think about it, if you're training people in the field, or if you're a policymaker, or if you're thinking about entering the field. The great thing to me about emergency medicine is it's not just the hospital. It's this whole community. You're the front door of the hospital, you're the open access, and you interact with the back end. So here you can see on this diagram, it starts on the left at the scene. And this is where emergency medicine starts, right here, with the injury and the bystanders. So doing bystander education, training, access numbers, having a number of people can call. Having then an ambulance and a trained provider with equipment come, a dispatcher that can coordinate these resources. And then a transportation mechanism that doesn't just transport the person, but has a provider in the back that can provide care and gets them to a facility where they're handed over formally to the intake facility and emergency department, and there's an actual transfer of care. So care has begun immediately, and now it's all a continuity of the same thing in the perfect system that we strive for. And then in the hospital, they're treated by their healthcare workers, they're resuscitated in the emergency unit, and then they have and consultants, and then they have a disposition. They either go to the operating theater, they go to the ICU, they go to the inpatient ward, or they're discharged and for outpatient follow-up, which really isn't discharge. That's not the end of the road. It's just like when we transfer care to the ICU, we transfer care to their primary care provider. So think of everything as just one big circle, and it's a big continuity of care, and that emergency medicine is really the very, very center of it, and that's why it's so important. And for so long, we lacked that center. And I think it's really a good thing for the healthcare system. So thank you guys all so much for having me here to talk about it.
Thank you, Dr. Sean. Our next speaker is Dr. Megan Rivercheck. Dr. Megan completed her residency training in emergency medicine at Boston Medical Center in 2017 and graduated with distinction from the Public and Global Health College, received the David A. Frommer Award for Academic Excellence. Her experience in the field of global health at Notre Dame and Johns Hopkins involved clinical work and research in Ecuador, Honduras, and the Democratic Republic of Congo. Dr. Megan will be sharing her thoughts on the practical consideration in emergency medicine curriculum development. Dr. Megan.
It is an honor to be here. Again, my name is Dr. Megan Rivercheck, and I am one of the International Emergency Fellows at the Harvard University Brigham and Women's Hospital program. And today I'm going to be speaking on the practical considerations of developing an emergency medicine curriculum. So I have no conflicts of interest regarding this talk. So to begin, first, what do I say when I mean an emergency medicine curriculum? A curriculum in the broadest sense of the term is planned education on a specific topic for learners at a particular level that is comprised of content, methods, and assessment, and that is aimed to achieve certain academic goals. More specifically for emergency medicine curriculum, it is a program to teach concepts within the realm of emergency medicine to trainees at a certain level, either in basic terms to individuals like medical students and EMS or emergency medical services providers, or more in-depth to residents or to even existing faculty. And it is doing so with a specific goal in mind, such as teaching medical students the concepts of resuscitation, or more broadly, such as developing an emergency medicine department at an institution, or emergency medicine as a specialty in an area where it has not previously existed. So how exactly is this done? I think my colleagues have mentioned this a bit, and I'm going to kind of continue on this idea of linking emergency medicine to almost like running a business, and it has to be something that you have to sell. So to help illustrate it, I'm going to compare it to starting a new business or a new company. Interesting enough, developing and implementing a curriculum is much like developing and running a new business or a new company. Many of the same principles apply. First and foremost, there has to be a market for what you're selling. There has to be a market for emergency medicine. There must be consumer demand and the capacity to support what you plan to supply if you want your business to be successful. These are basic concepts in economics. In terms of curriculum in emergency medicine, there has to be demand for the specialty, from the level of the patient to the level of the healthcare system as a whole. And furthermore, there has to be the capacity of the system to supply learners, as well as to support either the creation of the specialty of emergency medicine or the expansion of it if it already exists, depending on the status in the current healthcare system. And then all of the downstream consequences and broader implications to the system that comes from those changes. And to more specifically dive into this, still using the analogy of running a business, once you've determined that there is a market, then you need to comprehensively develop your product, or in other words, to create your supply. Likewise, with an emergency medicine curriculum, you need content. What topics are you teaching? Are you just teaching one emergency medicine topic like resuscitation, like I mentioned before? Or are you covering something, or are you covering everything that someone needs to know to practice emergency medicine? Second, in order to sell your specific project, you need organizational structure, style, and strategy, along with the necessary staff and skills in order to manufacture, to deliver, and to sell your product, as well as to manage the company. Likewise, to teach emergency medicine, you need individuals who know and can practice emergency medicine and can use specific academic skills and educational methods and strategy to teach trainees, but you also need a complete organizational structure in order to support those educators and trainees. That includes other services such as nursing, ancillary staff, and administrators, as well as all the other specialties as we talked about before. We are the center of the access and admission to the hospital, and therefore we speak the language of every other specialty that's in the hospital. And so we are that access point. Third, and back to the example of running a business, you need to do all this within the context of the current market and system, especially if you're introducing a novel product. And similarly, when introducing emergency medicine or introducing a change in emergency medicine in the healthcare system, you need to do so in the context of all the other departments within the hospital, as well as with consideration of the capacity of nearby hospitals in your emergency medical systems. Furthermore, you also need to consider the potential changes the implementation of this curriculum will have, and potentially the implementation of an entirely new specialty on the national healthcare system. And finally, at the very core, the key to making a business and also an emergency medicine curriculum successful is through shared values by all of the individuals in the program, as well as all the potential collaborators and stakeholders that may be involved. So why are shared values essential? It's not just the demand and the capacity to support the specific curriculum that are important, but successful implementation of an emergency medicine curriculum is dependent on all those involved, recognizing its importance and necessity, and ultimately realizing that the unspoken goal of the program is the ethical principle of working together to meet the needs not only of the learners and the trainees and the patients, but as well as the society at large. As I've already mentioned, implementing training programs in emergency medicine from the most basic level to the most advanced level can have far-reaching consequences. And when curriculum developers and educators come together, along with their learners within the context of the system, they have to be able to predict, to understand, and to manage the downstream effects, as well as to select the appropriate content, methods, and assessment to make curriculum not only a success not only in terms of reaching the academic goals of the learners and the trainees, but also working responsibly and ethically within the healthcare system as a whole. So I hope I have somewhat conceptualized what a curriculum is, and I hopefully emphasize the complexity and the thoughtfulness that must go into deciding to develop a curriculum, given its potential effects on the healthcare system. So I will now dive into more practical steps that you need to take to design and to implement a curriculum. We've already heard of some excellent examples that have happened here and some of the specific steps that you need to take. There are also excellent manuscripts that have been published in the United States as well as abroad, and also, as Dr. Kivlehan showed, there are many online resources that can help with development of a curriculum. What I'm going to talk about today is one specific 6-step approach that has been proposed, that has been successful in doing this. So first, what you need to do is to identify areas for growth. Second, complete a targeted needs assessment. Third, set goals and objectives. Fourth, select and design the educational strategies and methods. Fifth, implement the program. And finally, evaluate the learners and the program as well. So I'm now going to cover each one of these in more specific detail. First, and I will not spend too much time on this because I've already covered it somewhat, as well as some of the previous talks have covered this, is determining the areas for growth that need to be filled in by emergency training or by training in specific topics within the realm of emergency medicine. And this can be determined by reviewing data on quality of care, resource utilization, cost-benefit analysis, patient-provider satisfaction, and so on throughout your institution or throughout a region through methods such as surveys and focus groups and discussions at all levels, from the patients and administrators, so looking at the system in a vertical fashion, as well as across specialties as a whole, so looking at the system in a horizontal fashion. And through this you need to use a variety of methods, depending on the audience or the type of data you would like to examine. You can outline, in doing so, you can outline what the current approach is to providing emergency care, and then compare your system to other systems and data from other systems, and determine what the ideal approach might be. So it is in identifying the key differences between the current and ideal approaches that you can find that gap that your curriculum can fill. So once you've identified some of the broader areas for growth within a healthcare system, you must do a more targeted need assessment of the learners that you will need to train. Will a certification program work to train current physicians in emergency medicine, or do you need to create an entire residency program, or do you need to create both in succession so that you have supervisors that can train the new residents? You also need to train nursing staff or EMS providers instead, or do you need to also train them in parallel? Once you've determined the level of trainees, as well as the potential for formal licensure or certification of those learners within the current system, you can begin to generally assess the potential trainees' current skills and areas where they're looking to further develop, as well as their expectations and their styles of learning. For example, if you decide your trainees will be current physicians working in an emergency department, what skills do they currently have? What do they want to learn? And what are the methods that they prefer or have time for in terms of synchronous or asynchronous learning? If they're currently working in a department, what do they have time for? Is it something where they can meet for 4 hours a week in conference, or do you need to develop a more asynchronous curriculum such as online learning, where they can do their learning on their own time? You also need to do a further assessment of the learning environment, which I've already mentioned a bit before. How specifically will your curriculum fit into the current system? What type of certification or licensure will your trainees receive, and what does that mean within the current hierarchy of staff within the hospital? Who all should be involved as stakeholders in order to support it? Where will you obtain your resources? And finally, where can you anticipate challenges? To answer all of these questions, again, a variety of methods such as surveys, focus groups, interviews, and as well as talking with specific key stakeholders can provide this information. So once you've done this, you've done both your broad and your more narrow needs assessment, not only of the system itself, as well as your learners and your trainees, you can begin to construct the actual curriculum. So this should start by explicitly outlining your goals and objectives. And these will be used as conceptual and objective guides, respectively, for the remainder of the steps. First, the goal or the goals of the program. This should be like your lighthouse, your guiding light, your mission statement for your program. And it should be kept short. It should be 1 or 2 goals maximum, and something that's easy to remember. So, for example, a goal statement for an emergency medicine residency program might be to comprehensively train professional, independent practitioners of emergency medicine. So let's break this down a bit. To comprehensively train means you're not just covering one topic, you're covering everything that someone needs to know in order to practice emergency medicine. In terms of fully trained, that is also saying this is what is recognized in this area as being fully trained or going through 3 to 5 years of training for the specialty. The word professional implies that there is a formal certification or license for your training. And then in practitioners in this case, it could be further specified as physicians, given as a residency program. And then emergency medicine is the broad area that you're going to be covering within the specific area of study. So that's how you identify what your goal of your program is. In terms of objectives, and there should be many, many more of these within specific areas, and we've already talked about areas such as professionalism, skills training, medical knowledge, things like that. These need to be what we call SMART, or specific, measurable, achievable, realistic, and timely. And there should be an objectives created for both the learners as well as the program as a whole. So for example, a specific objective for learners within the context of doing procedures might be that trainees successfully place 20 central venous catheters in their first year of training. So this meets all the SMART criteria. You have something specific, you have something that's actionable, you have something that is achievable, and you have a time frame in which to do this. In terms of creating a comprehensive emergency medicine program, learner objectives should cover all areas of competency from knowledge acquisition as measured by tools such as written and oral examinations, as well as skills such as professionalism, procedural competency, and oral presentation skills as measured by direct observation or simulation. Likewise, as well, program objectives should be comprehensive in terms not only of measuring the overall learner performance, but also potentially patient and systems outcomes depending on the goal or the goals of the program. So once you've outlined your goals and objectives, you can then choose the actual content. So now we're finally getting into choosing the content to meet those objectives. So in emergency medicine, we've talked about this a little bit, balancing trying to cover too much or too little is always a challenge. And how long is your program potentially, 3 years or 5 years? Given that we're a specialty of breadth and not depth, as was mentioned before. As a result, it is good to ensure a specific focus on key concepts in order to meet your specific objectives, but also to build in flexibility regarding the amount of resources devoted to these core concepts and other ancillary topics. Regarding specific methods of teaching, this topic is way too broad to cover in such a short time, but suffice it to say it should be varied in terms of emergency medicine. As was mentioned before, we have a breadth of skills that we need to learn, not only things like medical knowledge, but also things like ethical considerations, procedural competency, documentation, the list goes on and on. And so you need to have methods of learning that start with more formal training, such as readings and didactic lectures and things like that, but also go into standardized patients, simulation, and group trainings, and peer-to-peer learning, things like that. And now, finally, to implementation of your curriculum. In order to successfully implement the content you have now developed and using the methods that you have selected to deliver that content, you need to ensure appropriate resources, personnel, time, funding, and so on, as well as political support. This is already something that will occur naturally, so when you look back to step 2, in terms of steps 1 and step 2, in terms of looking at your needs assessment, so that should have already started previously. However, the availability or lack thereof of these resources may cause you to have to go back and revise the curriculum. So this should be an ongoing process that happens the whole time throughout curriculum development. And then finally, when you actually begin the curriculum, you can choose to do so in a variety of ways, depending on the type of curriculum that you're trying to implement. And this depends on the resources that you have at the commencement of the program. So for example, you may need to choose a pilot or a phase-in approach versus a full launch. And each of these, again, depends on your barriers, your resources, and your political support at the time of implementation. And finally, prior to full implementation, you should anticipate and address any challenges, such as changes in funding or personnel that may occur during the implementation of the curriculum, and ensure ways to compensate or to adapt the curriculum. Again, we're a new specialty. A lot of people are watching how we do things, and so being able to be flexible and to adapt to any challenges that you might have so that your curriculum can be a success and not a failure can help early on. So if you can anticipate those and plan for those, that will help make the curriculum a success. And finally, evaluation and feedback is also essential in order to inform changes and adaptations to the curriculum and to ensure continued flexibility. Think of feedback as formative and evaluation as summative. Both need to be present to promote development and adaptation, as well as to draw conclusions and to ensure trainees and the program are meeting your milestones, respectively. And both should be comprised of pre- and post-assessments, tests, and evaluations, and self, as well as external or peer and instructor or supervisor assessment that will allow for multiple views of the trainees and therefore equality in assessments. Again, how to actually do this in terms of written or verbal evaluations, interviews, surveys, and so on is a bit of a broad topic and too broad to cover today. But it is a good idea, at least in the initial stages of development, to use a variety of methods to see which your learners and which the program might respond most readily to see which ones will avoid respondent fatigue, and to determine which is the most convenient, efficient, and effective way to evaluate both the programs and your learners in an emergency care setting. And in all of this, transparency of the process and confidentiality of the trainees and individuals' records are essential in order to ensure quality and to promote a safe learning environment for trainees. Additionally, transparency of the performance of the program to the trainees as well as to all of the stakeholders, including all of the other specialties in the hospital, is paramount to the success of the program. And one last note, as I've already mentioned several times before, curricula are not static. A curriculum will never ever be finished. Given the constant evaluation process that should occur, there is a need for flexibility and adaptation, and there will be areas that will need to constantly change. And using the methods you develop through your evaluation and feedback processes, you will be able to obtain the necessary information in order to do this. Additionally, in the long term, learner preferences, technology, and medical knowledge, especially in the field of emergency medicine, will continue to progress and expand, and therefore your curriculum must also. So with that, in summary, the process of determining the need for and the appropriateness of a specific academic curriculum, particularly one in emergency medicine, is one that should be thoughtfully and carefully researched and thought out given the implications it can have not only on the instructors and the learners, but also the patients and the healthcare system as a whole. And hopefully the 6 steps I have presented here in terms of identifying areas for growth, performing a targeted needs assessment, setting goals and objectives, determining educational strategies, finally implementing the program and maintaining a continuous evaluation feedback have provided an outline that is not only helpful in elucidating the process of curriculum development for those of you without experience in the area, but has given those of you who do work in this area some new tools to use. So that again, I thank you very much. It's an honor to be here, and I think we're going to be taking questions after this session. Thank you.
Thank you, Dr. Megan. Our last speaker for this session is Dr. Adil Akhtar. Dr. Adil is a trauma surgeon and researcher. He is also the Kessler Director for the Center of Surgery and Public Health at Brigham and Women's Hospital. He is also the co-founder of Dectilla, an online application to enhance doctor-patient communication. Recently, he has been the recipient of the Ellie Island Medal of Honor for his medical expertise and service to the less fortunate, a cause that is very close to our hearts. Dr. Adil will be sharing his thoughts on trauma care in ER setting. Dr. Adil.
Assalamu alaikum. How's everybody doing? We're good? Do we need to take a break? You want to stand up, everybody? Stand up for just a second. Come on, it's a very, everybody's been down for 2 hours. Yeah, here we go. We're going to get ready for lunch in about half an hour, right? So we need, what I'm going to do is, all right, you can sit down now. There you go. Feel better, right? Even just 5 seconds, helps you out, right? But what I'm going to do is, I'm looking at the time, and what I'm going to try to do is make my point very rapidly so that we can have more discussion. Because I think that the speakers that you just heard from are fantastic, and I feel as a kind of guest to you all of you, right? Because these are truly icons of emergency care. I work with 3 of the speakers here, and I know how fantastic they are when they provide emergency care. And then the rest, I mean, it's just amazing to see what you've done at JPMC. Congratulations on all of that. And yeah. I have just one suggestion, right? And the suggestion is that as Indus, and I'm thrilled to see this, by the way, is considering how to approach emergency care. Just one thing, that if you focus some of your emergency care training on trauma care, like really focus on trauma care, I suspect that you'll be able to really provide excellent emergency care as well. I mean, Yasin, you were talking about all the different things that we need to do, right, for what the EED specialists do. And many of those things can emanate from if you just do good trauma training. And I'm going to try to talk a little bit about that over the next, I'll try to be done in 10 minutes. How about that? Is that good? All right, so I'll cut half my time out. All right. If I can turn the thing on, maybe. Yeah, there we go. All right. So, This is the number of ER visits in the United States, about 140 million, of which 40 million, so a giant proportion of that is for trauma care, right? So again, the need to train people in trauma when you're training in emergency medicine makes a lot of sense. I tried to find data on exactly how many patients around the world are trauma patients in the emergency department. I could not find that data. But some good data from Pakistan is that there are a great many patients who come to the emergency department with cardiac problems, with heart issues, with chest pain and so on. And so then I was thinking, well, if you train people in trauma, can they get better at dealing with chest pain? And I was looking at the ATLS course, the Advanced Trauma Life Support course, and many of the things in ATLS are immediately transferable to what we would do to train people in ACLS, right? And so what are those, right? The basic concept of ATLS is ABCDE, and it's the same thing for ACLS, it's the same thing for stroke management, it's the same thing for everything, right? So if you train people really, really well in trauma care, you'd be able to provide excellent emergency care. And this paper by Terry Reynolds, and Sean, this one's for you, so you can go tell Terry that. Sean works with Terry. Shows that there's been some really good effort across the world describing trauma training. And I just wanted to put this up there, that trauma training, pre-hospital systems, and overall system organization are really what's been studied up till now. In this systematic review, that's what it pointed out. Other things still need a lot of work. So it seems like we know how to do training already. And here, this graph here kind of gives you an idea of what's the one on the bottom. That gives an idea of how many published papers are there out there that talk about training in trauma care. Now, one great thing that's out there right now is the WHO guidelines for essential trauma care. And they were just updated in 2016. And what I'm going to do is very briefly show how each guideline kind of gives a good recipe of what you need to train at least emergency care providers and trauma care providers. And so I'm just going to go through this a little bit faster. But again, it starts with the ABCDs, and then this is what that guideline has for managing an airway, right? And you'll notice that based on the type of hospital you have, it suggests how advanced you need to be. So if you are a secondary level hospital or a very primary level hospital where you can't intubate somebody, it talks about just doing chin lift and so on. If you have the ability to intubate, it talks about that. And if it gives good ideas on exactly how to intubate. And if you're a tertiary place where you can do an emergency airway or cryotheracotomy, it talks about that. So it gives a good kind of suggestion on your level of hospital and what kind of facilities you have. And what I'm suggesting is that as you train more and more people in the emergency department, if you use this, and I'm sure there are other curriculums out there, but my suggestion is that if there's a way to ensure that everybody knows how to do the stuff that's in the emergency, in this essential guide, then we'd be able to really take care of a lot of patients. And there are nice things in there, like how to do a cryotheracotomy and so on. Same thing with breathing. We were talking earlier, you talked about, this is Dr. Yasin, about putting a thoracostomy tube, right? Again, one of the basic skills for trauma management. And then again for circulation, simple things. We're starting with like putting in an IV, which in some instances is not the easiest thing to do, but it is essential to resuscitate the person. And sometimes you lose people because they don't have an IV. And I remember seeing a patient and seeing that happen once. Nobody can get an IV, so the person died, right? To putting in a central venous access catheter, if you have the capability, to putting in an IO catheter, if that's something that is needed, especially amongst children. So if you look through that guideline, through these guidelines, you'll find that all the things you need to do to train trauma fighters is in there, and that can easily be translated to emergency medicine training as well. Similarly with the disability and then exposure. So like all of those things are there. The other thing that trauma has done a lot on is this focused abdominal sonogram for trauma, or FAST exam, right? And I really think that there is a huge opportunity, and love to hear more in the discussion what you all think, about the use of ultrasound in emergency medicine care, and then of course in trauma care. We, of course, in trauma care use a few different views and positions to look at or screen patients who may have specifically blunt abdominal trauma and have a lot of blood in their belly, and people who need to go to the OR, people who have blood around their heart and who need to go fix that. We're able to find out those things using ultrasound. And I think that there's been some really good work around the world showing that you can train people in using this kind of ultrasound. This is data published by Tafoya, and what they show is that you can do this pre and post test here. This is pre-test and post-test some ultrasound training for people in a training program in Africa, and extremely good results on how well you can train people in using ultrasound. And just one or two things I wanted to also cover, and that is use of massive blood transfusion. Right? Again, I think a very important core trauma skill. Again, something that can be easily translatable to emergency medicine training, right? And I know the emergency medicine colleagues, at least where I work, you know, when they hear about what kind of trauma is coming in, it's a gunshot wound and the person's hypertensive, they'll be quicker than us to say, hey, let's get the massive transfusion protocol going and so on. And that really, really helps us. And so these are those guidelines for essential trauma care. They're easily downloadable, and they go over all the things that you would need to have a basis to start, EM training. So I'm just proposing this as a platform on which to build on. And then finally, the WHO has their trauma care checklist, which I think is really, really well done, and it helps with passing off, especially patients one after the other. And this is what the checklist looks like. It is not the most complex checklist, actually. If you look at it carefully, a lot of it is common sense. But what it does is that it ensures that these commonsensical things actually occur, right? Like turning a person and making sure they're not injured in their back and things of that nature. And the first study on this suggests that of 17 process measures that are out there, 16 improved because of the checklist. So certainly the checklist helps. They didn't see a improvement in mortality for all patients combined, but if you look at this graph here, this chart here, all the way on the bottom, here, ISS 25 and above, those are the most severely injured patients. And for those severely injured patients, look at the odds ratio, the odds of death, and you see a positive constant interval here. It's halved, right? So 50% decrease in death for injury severity 25 and above after using the trauma checklist. Basically, I think the way it works is that it just prevents you from missing giant things that would otherwise kill a patient. So again, another great way to use this as we begin to train people in emergency care. So with that, I hope I'm done under 10 minutes. Thank you so much.
Thank you, Dr. Adil. I would now request Dr. Saima to kindly come and moderate the panel session on redefining emergency care.
Thank you, all of you, and a special vote of thanks to all our panelists who've been wonderful in enlightening our audience about the emergency trauma care, emergency medicine, the various aspects. And what I feel is that when you hear all of them talk, it's like we are on the same page. The same problems that we are perhaps facing at Indus are the problems that are being faced at somebody working in Boston, or by people working at JPMC, or by people working in Shifa International. And that sort of knits us all into a small little tight group. And we need to take this forward and perhaps build upon it a long-lasting relationship in which trauma care can be integrated not only across Pakistan, but also at an international level perhaps later on. And this brings us together. So I think we should take that forward, and we are open to questions from the audience. Our panelists are here, and I'm sure they would be very happy to take your questions. So anyone?
Thank you so much, especially Dr. Seemi Jamali for taking initiative in government sector while establishing a training program, and Dr. Junaid, Mustafa, and Dr. Nadeemullah for doing a similar thing. in private sector. My question to the panelists, I mean especially those who are stalwarts of emergency medicine in Pakistan, is there a collaboration, or has there any steps taken to develop a collaboration among the emergency departments? I know getting a training program running is an excellent thing. That's the best you can achieve. But what is the collaboration among the emergency departments, that if somebody is lacking in some specialty, i.e. a pediatric emergency, pediatric surgery or a neurosurgery, what can be done to help each other? The second question is, with especially those who are working for college and like Dr. Seemi Jamali, who's working for college for the last 20 years, what steps has been taken to improve our pre-hospital care, where the 50% of our mortality lies? Thank you.
Yeah. Thank you. I think from my side, I think most of the questions, the answer will be a Society of Emergency Medicine working towards the all issues of the Pakistan, especially emergency department. I think on the society platform, our first couple of agendas are the minimum standards of emergency department of any district or tertiary care hospital. And other one is till now we don't have the resuscitation council of Pakistan at home. So that is the second option. So I think answering to your first question is that whatever collaboration is going to make, it's, because being a Shifa, I can't talk to higher authorities. Being Indus, maybe Dr. Bari is at times having a difficulty, although he's having a long hands can penetrate all of it. So, but in the whole history of all these specialties, I think the society is the main platform where we can talk together, and we are actually in the process of coming up as a society in next couple of months, inshallah. Regarding the CPSP or college, none of us are the representative of college, although we are in the faculty members. But I think this is also one of the top agenda in the grandfather clause to all senior expert members who have not gone through the training module or got the training degree of emergency medicine. But I think this happened throughout the world actually in the past, in America and USA. But all the people who have been working for so long, they've been given the chance to come up as a supervisor and as a leading person. So again, on this topic, again the society will talk loudly to higher authorities, either university, college, or even above to them.
Thank you very much. First of all, I'd like to thank all the speakers who've been here this morning and given us an elaborate talk about emergency medicine. As for your question, Dr. Saab, I just want to tell you one thing, that I understand that pre-hospital care is one of the most important things that we should have had in our province long time ago. Unfortunately, it was not developed by the government, and so far it's very poorly catered to by the government. As Dr. Junaid had already said that he heard the Federal Secretary Health speak in the inaugural session of the ICON, that only less than 1% of the GDP is catered towards the healthcare. So I think ED, Shifa and some of the other organizations had done a good job for a period of time in the city, that they were commuting patients from the site of the incident wherever something happened to the hospitals. But that was just preliminary. They were merely objects of transportation. The Aman Foundation, I must say, has done a very good job in the province of Sindh, particularly in Karachi, and now they've been hired from Karachi to Thatta or somewhere to that effect, from where they can commute patients. But we have seen these bomb blasts. We saw one in the outskirts of Karachi at the shrine, at one shrine, and how we were desperate and no patients could have been moved to Karachi. And we also saw that we've seen a number of incidents, We're doing a project with ICRC, in which healthcare in danger. Indus Hospital, Jinnah Postgraduate Medical Center, the Apna Institute are all partners in this project. And here we saw that how these ambulance drivers, because of their trying to help patients, were not able to transport patients in time to the hospital. Either there were so many hundreds of reasons, but there also because the ambulance doesn't have the proper space to try and resuscitate or manage patients inside the ambulance. Other than the Aman or the St. John's, I suppose that's another ambulance which can help. But I think there are no ambulance services. Frankly speaking, these are all transportations, methods of transportation to hospitals. So I think something needs to be done there where, and nobody is in charge. Like when you go to a place of, for example, this train accident that picture was shown at the Landi site, there was a train accident outskirts of Karachi. There was, nobody was in charge of that operation. Nobody takes charge. I don't know who should be the person in charge. There is no team that has ever been devised to be in charge of a certain incident. So there must be an incident command and control center. Wherever something has occurred, there must be somebody who has to be in charge and then go on from there. But I think this is something that the government needs to look into, and we can give all our suggestions, but it is for them to execute the system.
I'd like to ask a question from Dr. Junaid, especially. Sir, as a person trained in internal medicine, if someone wants to go ahead and take emergency medicine as the way forward, how would you guide that person? What should that do?
At the moment, what college is, because you're asking about the coming to the emergency medicine training program or as a senior in the training program. At the moment, the college is allowing people who have done their internal medicine training and finished the exam as well. And if they are interested in coming and transforming them into the emergency medicine, they need to be in the emergency department as an employee and work for a few years. It's a post-fellow 3 years they need to complete, and they can be a supervisor. This was actually allowed about 3.5 years back, and the cap was taken off for 5 years. I think in the next couple of years that will be reconsidered as well. On the other side, we are also working on the lateral entry on the intermediate module, in which we actually asked college to allow people to come through the post-IMM, either they have done in medicine, surgery, peds and anesthesia. So they are 3 acute specialties. If they have done their intermediate module, which are 2 years training and exam, they can come to the emergency medicine as a post-IM and spend 2 more years to 3 years and pass or sit for the exam. And also we have asked them to allow the second fellowship as well, which the college promised us a long time ago, that when you will finish your first cycle of 5 years, now we have alhamdulillah got 2 fellows in Pakistan who are locally trained and qualified. So I think within the next few months' time, this will be up on the college side, that they are allowed to have a lateral entry either post-IM or post-fellowship, second degree.
I want to add to that. I just want to add to that. And it's working. Oh, it is? Both of them. I just want to add to that. So, in the United States, this was an opportunity as well, because it's a huge portion of the workforce that is experienced and could provide faculty, especially when you're scaling up a new specialty, because you need people to staff these emergency departments that are at an attending faculty level. And although they may not have trained in emergency medicine, that's because there was no emergency medicine training. It doesn't mean that they haven't been working in emergency departments and that they don't have valuable skills that can then be repurposed. So in the United States, they had they called it the practice pathway, and that was open for, I don't know exactly how long, but somewhere around 5 to 10 years. It's long since closed now, but that was a way that clinicians that had been working in emergency departments de facto for their careers could then become formally seen as emergency medicine physicians. And I imagine that most other countries that, as they started the specialty, had some similar things. So try to be useful to look for some guidance.
I did some very rough numbers, and for a country like Pakistan to wind up to staff, say, to a similar level to the US or to the UK, it would need somewhere between 10 and 20,000 specialists. That's not to say that the US or the UK model makes sense for Pakistan, but there is, but to get anywhere near that is going to require some flexibility in terms of how you train your specialists. If you wait for your current supervisors to train people and then to train people, that's going to take somewhere between 50 and 100 years, and I don't think that you want to spend that much time.
Especially being an emergency physician.
Next question.
Dr. Shahzad Ahmed Khan from International Committee of the Red Cross. Thank you for the excellent presentations. I asked the panelists two questions. One is that you've said that you have the emergency field has evolved. So does it make any connection with public health as well, community-based, or your SOPs are only clinical, or are you working in coordination, like for management as well? That is the first question. And secondly, I would like to ask Sean that he has experience of setting up emergency in Africa. So do you feel that these models are replicable, or we would have to reinvent the wheel in the third world countries? So these are my two questions. Thank you.
Thanks for the questions, and I'm sure other people have opinions too, but I'll start, and I'll say the first thing for the emergency department. The first thing for the emergency department is that it does not exist in a vacuum, which is the great thing about it. You interact with everybody else, so everything you do has to be done in conjunction with the other departments and administration and the public health system outside of the hospital. You really have to include all the stakeholders and work with them, because you can't just unilaterally decide to do something in the ED. It won't work. And the best way is to get as many people into a room as possible and ask them, what do you need? Don't come and say, this is what I need. Come to them and say, what do you need? How can we help you? And then you'll find solutions and you work from there. So, and that's every stakeholder, and somebody you may not think about. And like the IT thing keeps coming up, but it's such a good example of somebody we don't think about that's crucial to our performance. So, so the second question I'll address quickly is can we use previously made EM programs as a template? And I think to some degree, yes. A lot of work that we've done in AFEM and with the WHO now, and that IFEM strives to do as well, is to create a framework. And a framework, by definition, is a loose framework. It's not detail-oriented. It gives you the very basics, the foundation, and then you build your house on top of that. And that house will look different, not just in every country, but it will look different in every city. And even in the same city, it may look different in different parts of the city. But it provides that foundation. Those resources have been very well thought out by fairly diverse stakeholders. And I think the AFEM name is deceiving, because it's really not just African. There's people from all over the world have been involved in it. So I would look there, IFEM, there's a lot of resources, and it's meant to be that initial guidance.
Sure, I've got one more question for you. Could you just elaborate a little more what you have done in Tanzania and Haiti? That how did you manage to get a 3-year program, and what was the challenges? Just a brief one.
Well, first start that was that I was one small cog in a much larger wheel of people, and I was part of a very, very large team, and of which I was not the leader. But it was a great experience for me to see. And I'll tell you, the way you get it done is negotiation and being nice to people, and that's why you have to provide value. It has to be you can't go in and say this is the right thing to do because it's the right thing to do. That we may believe that, it may be true, but that's not enough. You have to say, this is the value added, both ethically in the healthcare system, but also financially, and be able to make a true financial argument. Because at the end of the day, there's that saying, no margin, no mission, and it's very true. You have to be able to convince the hospital, you have to convince because the hospital had been there already for many years, and you have to convince them, you have to convince the leaders of the other specialties, you have to convince the government that this is worthwhile, this is worth paying for, this is worth giving us square footage, training capacity, things like that. And the way you do that is start by asking them what their problems are, and then when you hear their problems, you'll hear that these are problems that the emergency department can solve. And that's how you present it, as a solution, not as a new thing that you want to do. But it's negotiation. It's not going to turn out the way you want it to, but it's still going to turn out in a great way. So you have to be very flexible, which was brought up earlier too.
I was just going to make a comment towards the when somebody asked about public health and the emergency department. You know, for public health emergencies, many emergency department leaders have really taken that on. So most of the disaster medicine in the United States is really run by a lot of emergency department physicians, where we all work. The head of disaster management is a guy called Eric Garlick. He is an emergency medicine physician, and all the way to Washington, D.C., where the National Security Council, the disaster medicine folks are all, emergency medicine colleagues. So that's another great role. So you were talking about who should be the incident commander. EM folks are the great people to do that.
We have Nadeemullah.
Can everyone hear me?
Yes.
Assalamualaikum, my name is Dr. Amar Ahmed. I'm a graduate of Jamali College. Regarding Dr. Saab's question about pre-hospital care, I've been itching to contribute some information regarding work an NGO has been doing here in Pakistan. The NGO goes by the name of First Response Initiative Pakistan. We teach emergency first response to medical and non-medical personnel. Now, I've been hearing words like society and public health. Now, in addition to your ER physicians, a lot of the role, it falls on your common man as well, because the golden hour is very important. And say you've got a trauma patient that comes in and they've been mismanaged. So if that person's been thrust onto an ER physician and that person's been mismanaged, so they can't really do much and they're expecting a lot. So FRIP, which is the NGO, we teach emergency first response to both medical and non-medical personnel. We're targeting medical professionals, training them into instructors, and then those instructors move on to teach other people as well. So like this past year, we've conducted about 60+ workshops, and the vision we have is that we need an integrated system for ambulance services as well, where it's not just about scoop and run, but you have paramedics that are actually trained in this, that are actually trained in first response, and they can. So basically, people won't be mismanaged. Pre-hospital care, I think on that front, it needs to be tackled a lot. If a lot of the ambulance services, they're not integrated either. 4 ambulances will flock to the scene. They will not be able. They'll fight over the cost, and then it's handled from there. So a lot needs to be done, and we need to integrate NGOs as well regarding this. So yeah, that's pretty much it.
I'd just like to add one comment at what you've said. It's very good, but more than the NGOs, because all these NGOs have some vested interest in whatever they are doing. It's unfortunate, but they have some kind of vested interest. And as you rightly said, that I have seen that myself. I've worked with her 30 years, 3 decades in an emergency place like JPMC. And I see how they fight over trying to cover dead bodies with the sheets and having their logos displayed and things like that. So I think it's about time that the government takes this up. And for example, we're not very far away from that. Rescue 1122 is in the other province at Chisholm. And something of the same kind can be taken up by the government more appropriately. Aman is doing a fantastic job, and if you look at how they're working, I think it's a very organized system. The only thing is you need to put brains together and get people on board, and then get government and private partnership, and I think that would be the best way to go about it. But the onus has to be on the government because it's basically their domain.
No, I agree very much, and I see there being, just to kind of add to what you're saying, I think that there is really, the future is some form of public-private partnership. I don't think that it's likely that the government is going to be able to staff and run and buy ambulances for the entire city or for the entire province. But I think that the core role for the government, I would imagine, be in a central coordinated dispatch center. And so if you have a single phone number, a coordinated dispatch center that the different private actors and NGO actors can wind up participating in, I think that that kind of coordinating role could take advantage of the resources of multiple different actors, but with the government coordinating and regulating.
Any more questions?
Dr. Zayed from Indus Hospital, currently working as a medical officer there. I heard Dr. Junaid talking to the Minister of Health about the defense budget, and he said that it's about less than 1%. So I wanted to ask, just curious, how much does that less than 1% quantify in terms of rupees, and how much does that compare with the defense budget of other specialties?
So very critical question. It's less than 1%, and most of that is in the non-developmental budget and so on. I don't know exact the figure is, but what I also remember when talking to the health minister in Kashmir, in Azad Kashmir, Pakistan part, he was also telling the same story, that his budget was, again, the whole budget for the health was more than 50% was on the pays and pensions, and few for just the medication, and there was nothing to have to develop more things. So yeah, I mean, this I can't compare it to the defense budget, but defense is important as well. So because army is very important, especially in Karachi. So I just want to do a concluding, just a final remarks. Again, I would say to all of my, especially emergency medicine family, that we need to come up all together with a national one voice, especially at least like we have done this thing in some parts of Pakistan. We don't have the national triaging system at the moment, which is the most urgent need for all the hospitals in Pakistan. We haven't done the minimum standard of the emergency medicine. I think we are the people who need to develop those things. And the last thing is the resuscitation wise is the Aga Khan, maybe CPSP and few hospitals in the army who are only in a couple of pockets they are running the resuscitation courses. So it should be come up with a National Resuscitation Council, and they should actually look after all the trauma and the local guidelines actually. We have got a totally different experience locally. And similarly, we need to talk internationally like IPM, and we are actually in the process of doing the membership and everything. So this all very important talks. I think the organization like Indus and Aga and Shifa and now JPMC and all other hospitals, they need to come up, and then the joint voice should come up. Dr. Salam.
Assalamu alaikum. I'm Dr. Sana and I'm working with Aman Foundation, and thank you so much everyone for your talks. So everybody's talked about pre-hospital care, and I'm not going to put up a question because I'm already working in that sector, but I thought it's kind of important to just put it out there. Yes, we have several partners when we talk about pre-hospital care, and Aman is one of them. Just to put it out there, everybody has kind of pointed out the role of the government as a public-private partnership. So the good thing is that the government has already put in a hand in this. They're coordinating with Aman, and they've extended. Aman has developed a public-private partnership in terms of developing Karachi itself and extending their ambulance services in Karachi as well as in Sindh, which we're working in two sectors, which is Badin and Sajawat, and we're going to extend further as well. On the other end, we are trying to improve the pre-hospital care system in terms of improving pre-hospital care, their teaching systems, and developing updated systems like telemedicine as well. So these are some of the things that Aman is trying to push on their end. We are also trying to coordinate with EB and Shifa, who are key members in the pre-hospital setting. And we hope that collaboration will we'll be able to kind of get there, sooner than later, because that is the agenda, and that's how we're going to progress. So that's just a short bit on my end on pre-hospital care.
So at the end of the session, what we have learned perhaps is that an integrated approach, instead of working in our own little circles, we need to get together, improve upon our pre-hospital care, our hospital care, and later the definitive care that has to be provided by the people to whom we hand over the patients. So I would like to request Dr. Seemi to kindly conclude the session by a few remarks.
Well, I think this has been one of the best sessions that I could have heard this time. It was brilliant to hear Dr. Adil, Dr. Zayed, Yasin, Dr. Junaid, Dr. Nadeemullah, Dr. Megan, and Sean. And of course, doctors from my hospital, Jumeirah, and Dr. Saima. And I think the best approach would be an integrated approach, and I think that is the best way to go forward. We need to now go forward, and it's high time, we get onto petty issues and, crying and cribbing over small things. We need to move forward. And I think this is the right time and this is the right opportunity actually to move forward. And I think these were wonderful presentations. Every aspect of emergency was covered, and also the trauma, because I want to say one thing, that some time ago we had done a research on the kind of patients that came to the emergency, and we saw that about 65–70% were medical patients with medical emergencies. And right now, if you look at the emergency department of our hospital, it is about 45% of the total number of patients that are coming right now are those of trauma. So it could be a firearm injury, it could be an accident, it could be just a head injury, it could be from anything. So I think that trauma also needs to have a significant role in the Department of Emergency, because if we cut that out, then I don't think we will be able to achieve our target. So thank you very much everybody for making your presentations and being here.
I request Dr. Abdul to please come up on the stage and distribute the sheets to our participants. Dr. Khwaja Junaid Mustafa. And Dr. Nadeemullah.
Okay, sir, look at.
I would now like to request the medical director in this hospital to come up upon the stage, Dr. Asht, and distribute the rest of the sheets. Dr. Sean Kivlehan.
Sir, please look here. Wait for video. Thank you.
And Dr. Megan Rubarchek.
Ma'am, look here, please. Then. Thank you.
Dr. Javeria from JPMC.
Okay, look at the camera.
Thank you.
And Dr. Saima, JPMC.
Okay, look at the camera.
Done. Thank you.
So this brings us to the
वेट करेंगे वेट कीजिएगा वेट 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 Thank you.